Young. He has
Good
lost
evening.
5
Good
kilos.
evening.
Maybe Chitra, your eyes have become young, so everybody is looking younger.
Nothing like that.
Kamaljeet Saab,
Yes,
happy
sir.
birthday.
Thank you so much. Actually, my real birthday is on 15th October.
ये कोई तरीका हुआ?
दो मनाते हैं, 15 अक्टूबर का याद रखिएगा.
We are live.
Okay. Very good evening to one and all of you. And I truly look on this being a part of this webinar, although an ARC webinar, but working with some very dear friends in this SICs group is definitely going to add joy, flavor, and lot of learning as we go through the next 2.5 hours. There are two of us expert panel who have yet to join. However, I would introduce them. We have joining us Dr. Debashish Bhattacharya, who is a founder chairman of Disha Eye Hospital, past president, and a very dynamic, prolific surgeon of our country. Joining us soon, hopefully, is Dr. Lahane, who is a immensely known, popular, dynamic personality, a leader of the Maharashtra State Society, and a national figure of Indian ophthalmology, who has not only been a great surgeon and ophthalmologist, but has had forays of immeasurable dimensions in community ophthalmology. We have with us, and are very lucky to have with us, Dr. M.S. Ravindra, who's the chairman and medical director of Karthik Netralaya, and a management trustee of Netro Jyoti Foundation, and a founder director of Jyoti Lasik, and the president of Bangalore Ophthalmic Society. And more importantly, he is going to show us some amazing videos, and which is going to remain as one of those greatest pearls of learning in this SICs webinar. We have with us Dr. Jagannath Boramani, who is a consultant at Surya Netralaya in Vasi, Navi Mumbai. He is presently the executive chairman of ISMICS Group, a leading figure in Maharashtra State Society, and of course, very immensely popular and known as an in the national ophthalmic scenario. We have with us our ever smiling, ever encouraging Dr. Amulya Sahu, who's again a practicing ophthalmologist from Mumbai with 3 vibrant centers, and more importantly, how we all know him is a founder chairman of this ISMICS group, which has just grown in strength, not just within the country, but abroad, and has done wonders to strengthen this organization. And we are truly lucky to have him with us. Moderating and joining soon would be Satyajit Sinha, who's my ARC member.
I'm here, ma'am.
Hi, we need to see
Hello,
you, member ARC East. And he's the chairman and medical director of AB Eye Hospital. He's a specialist in cataract, glaucoma, and refractive services. His second term as an ARC member, and truly a friend. Everybody would look upon him as their own personal friend, and has an immense standing in the national ophthalmic scenario. We shall start with our first speaker, Dr. Tamilarisi, who's a senior consultant cataract and AIOS services at the Eye Foundation Group of Hospitals. He's also a surgical trainer and is an extremely prolific, versatile surgeon, and has an excellent concept in what ophthalmology actually means in all its terminologies. And she's going to start off with a very simple topic, which is so quintessential to doing a good SICS surgery. And she's going to be talking on premature entry, scleral disinsertion, buttonhole, how do I manage all these dreaded moments. On to you, Tamil.
Thank you, ma'am. Thank you for your kind words. Very good evening, all. Today, I'm going to talk about managing tunnel complication. A key aspect of small incision cataract surgery is the structural integrity of the tunnel. It means the tunnel has to be self-sealing. The second important aspect is the magnitude of astigmatism we are going to induce or correct with our incision. As I said, like managing complication, if you are going to have a buttonhole, we can easily say that make a superficial tunnel and proceed. And if you end up in a premature entry, reform the AC, create a superficial tunnel, and in the end of the surgery, suture the premature site. or if you have a scleral disinsertion of your groove, suture it completely and shift to another site and proceed. But I feel this is truly a preventable complication if attention stays behind the principles of tunnel construction, which I'll be talking in the subsequent slides. So the first and foremost important thing is the patient positioning. See, the upper right video shows a superior sclerocorneal tunnel video, and the upper left is a temporal. So for a temporal sclerocorneal tunnel, I always keep the patient head with the iris parallel to the floor, chin in a neutral position. For a superior tunnel, I lift the patient's chin little up. This gives a better positioning and the surgical view. Whereas the lower left shows that the head is down and chin is rotated down, and the surgical view is not going to be great, and the positioning and maneuvering of the crescent blade is going to be difficult, and we can have a complication which I'll be showing in the subsequent video. The second important thing is, if a surgeon is going to see better, as a surgeon, we are going to operate better. So conjunctival dissection along with tenons plays an important role. For a beginner surgeon, I advise always to give a small relaxing cut in the extreme other end so that the conjunctiva does not fall back, and give a judicious cautery of the bleeders so that the oozing is not there. For superior tunnel, we can also, the superior rectus bridle suture plays an important role where it rotates the eyeball down and also gives a traction for performing the tunnel. The second key aspect is a fixation. Hold both the conjunctiva and tenons together and never press down. Lift it gently. And I discourage holding the tunnel lip because it can compromise the structural integrity of the tunnel. Another way to get a good fixation is making a small posterior scleral groove, and holding this gives a better fixation and counter traction for tunneling. The third important point is the incision site, size and shape. Site, a beginner surgeon always have to keep in mind the anterior limbal border and measure 1.5 to 2 millimeter behind it. So this is the site of the incision. And the shape and size for a beginner, it is always to go with a straight incision, which is around 6.5 to 7 millimeter. Later on, they can modify the size and shape depending upon the nuclear density and the method they are going to use for nucleus delivery. If they are planning to do a frown incision, they can take a central point which is 1.5 millimeter behind the anterior limbal border, and the two extreme points 1.75 to 1 millimeter behind this, so that when they're connecting the three dots, they will end up in constructing a frown shaped incision. The fourth point is next is to achieve the correct plane of the tunnel construction. So with the tip of the crescent blade, sweep from end to end of the groove, so that this acts as a windshield wiper movement so that we can achieve a uniform plane. So once you get a plane, the next step is to assess the depth. This is a critical step to prevent a tunnel complication. So look for the visibility of the crescent through the sclera. Here the visibility is not there. That means the tunnel is deeper. If it is translucent and if the roof is bunching up, it means the tunnel is superficial. What we want is a transparent looking crescent through the scleral upper roof. So once you confirm this, proceed with the tunnel. Again, I'm re-emphasizing the fact with these two videos, whereas the upper right, you can see that the roof of the tunnel is also moving along with the crescent manipulation, and it is the view, and the view of the blade is translucent, so it is superficial. Whereas the lower video shows that the tip of the crescent blade is not even seen, that means deep. So stop here, again find a correct plane and then proceed to avoid a tunnel complication. The starting site preference, I usually start in the center of the tunnel and then sweep on either side across, but it is the individual surgeon's preference. If a beginner surgeon always have a problem towards the right side where a surgeon ends up in a buttonhole or a premature, I would advise them to start from the right extreme end of the tunnel and sweep across the other side. So it is left to the surgeon's preference. While completing the sclerocorneal tunnel, so always we have to take into account of the change in the curvature from the sclera to the cornea at the limbus. So at the limbus, the surgeon has to keep the heel down to account this of the change in the curvature. Otherwise, he will end up in a premature entry. And the second change in the curvature happens when we are tunneling towards the sides. So always tilt your crescent little bit. If this is not done, if the crescent is going to be straight, as shown in the red arrow, we can have a buttonhole on the extreme sides. So take into account of these two change in curvature while doing the tunnel. And the extreme end of the tunnel, always do a good side pocket so that it can accommodate the larger grade nucleus. Another point to be kept in mind is keep the crescent always straight. Never tilt the crescent too much. Here you can see towards the left hand side the crescent is being tilted too much. So another groove has been created rather than the intended groove which is already made. So always when coming out, keep the crescent straight and then come out like this, and don't tilt the crescent. The next step is the keratome entry. So keep the tip of the keratome at the anterior end of the tunnel created, dip in, enter, and then cut during forward movement. So what we expect is a smile-shaped inner lip, which is larger than the external groove. So the shape of the tunnel is almost like a trapezoid. Here I'm going to show videos of tunnel complication. Here we can see that while starting with the tunnel construction, you can see that the roof is moving. It's almost it's superficial, and the attention is not paid here, and the surgeon is continuing the tunnel construction. And you can see that the tunnel, the crescent visibility is more towards the left hand side, and a buttonhole happens with subsequent tunneling. So stop here. Since it has been started in the center, so the trainer is correcting from the left hand side. So once you're done, first assess the depth if it is correct, and keep in mind of all the principles which we discussed now, and proceed with the tunnel construction, keratome entry, and then complete the case. This is another case. You can see that the groove is little posterior than expected. It is around more than 2 millimeter. And while starting tunnel construction, the depth appears at, correct only. Here it is not superficial. But what happens at the limbus, excessive tilting of the crescent, thinking that the heel has to be down, the surgeon is tilting, so it is almost like a buttonhole there. And you can see this red dot, which is towards the left hand side, is a buttonhole which has happened. So to go past this buttonhole, tilt your crescent, lift the heel, and then create a plane behind this superficial buttonhole. So it is being tilted. So we are getting a deeper plane behind this buttonhole, and we can create and then proceed. So we are getting another new plane behind this small buttonhole which has happened. So this is a case of a premature. We can see that the visibility is not at all there, and a small premature has happened. So if a premature happens, the first step is to reform the AC. Take care, you're not going to damage the iris. And once the AC is reformed, again create a superficial plane, look for the visibility of the crescent. Once you confirm this, take into account of the 2 change in curvature, and then complete the tunnel. And while placing the keratome, make sure that it is placed in the new plane, not in the deeper plane, and then cut. And always suture the tunnel at the premature site so that the tunnel integrity is not compromised. This is the case which has been showing in the first, where the head positioning is not correct, the chin is down. So you can see that the positioning of the crescent becomes a problem here. So the positioning, the heel is always up even from the beginning of the tunnel construction. So the tunnel is always deeper. You cannot see even the crescent visibility. And while maneuvering, a premature entry has happened. So whenever a surgeon has a complication, it is better to review the video, assess why it has happened, so that they can learn from their mistakes. So as I said, the premature entry, create a superficial plane, and then proceed with the case. Scleral disinsertion, though rare, whenever we are making a groove, always make sure that it is done in one step. So here the surgeon is deepening the groove at multiple times, even with the blade and also with the crescent tip. And while doing the sclerocorneal tunnel, the surgeon is having a little suspicion that the AC is a little shallow, but with hesitation, the tunnel is being continued. And to note that the uveal tissue has started to prolapse from the groove. And also a bleeding hyphema has also happened. So this is a scleral disinsertion. So we have to suture the groove completely and shift to the temporal side. The last point which I want to emphasize, whenever the tunnel integrity is compromised, never hesitate to suture the tunnel. Thank you for the opportunity.
I think it was just a terrific video. I mean, every single point has been beautifully brought out, and I look forward to thoughts of our expert panel on this. The very first question which I would want to ask is, any of the expert panel could answer, when you are trying to train your trainees, we know that whether it's a tunnel construction or the rexis are those critical parts of SICs surgery. So how do you go about training them? Yes, Dr. Debashi.
Yeah, I think the best way to train is on a wet lab where you use a both side and you can do all the maneuvers that Tamilisari, the doctor, presented so well.
Yes.
And essentially, there are certain points which have to be put into their mind before they go through the whole exercise. Dr. Tamilisari actually mentioned most of them and in a very nice way. I would have one or two observations. One is, the external incision is very important because the external incision actually leads to the scleral tunnel. And in case of a beginner, what happens is they are a little shy. So when they make an incision, so the initial part, that is the left side of the beginning of the incision, is usually a little shallow. Whereas because our eye is like a globe and it is curved more in the center, so even with the same pressure in the center, the external incision becomes a little deep. So a conscious effort has to be made, and that is why we have a buttonhole in the center and a premature entry in the center and a buttonhole in the peripheries, because that is where, because of this curvature. So these things have to be brought into their mind. And the most important thing, which doctor has already mentioned, is the fixation of the globe with the forceps. And in fact, you have to constantly keep in mind that whatever we are doing, suppose we are making the first split of the external incision into the scleral tunnel. So if we are moving from from left to right, then the forceps actually holds the globe and gives a counter traction from right to left in the opposite direction. So in that case, it makes the workability much more smoother. And the third point that I would like to add is essentially the internal incision is most important, because if this internal incision, that is the corneal valve with the internal incision, if it crosses the limbus, then the incision becomes not self-sealing. So essentially, when the first entry into the anterior chamber, the keratome must be absolutely parallel to the external incision. So then we get a cut which is absolutely parallel, and then we can enlarge it on either sides. But if we go, say, suppose we go from 2 o'clock to say 7 o'clock. So if we go in this direction, then it will be diagonal, the internal incision, and then it will create a corneal valve which will run into the periphery at some point on the right side. So these are the problems which we have to instill into their mind before they really, because the incision is the main thing in SICs. We have done a good incision, then the rest of the steps are very easy to follow.
But if the conjunctiva is very thin, how do you deal with that moment?
Conjunctiva, so you are taking away, Chitra. So conjunctiva and tenons have to be neatly cut and kept aside. What you hold is the sclera. So you don't hold the external lip of the incision.
No, I meant the part when you're fixating the globe. On that side, the conjunctiva is not cut, no?
No. But you don't hold the conjunctiva or the tenon, or you hold the sclera.
Yeah.
You hold
have a deeper hold.
Sclera, and actually the forceps, the quality of the forceps also matters. For everybody's notice, I would say that, keep a good forceps. It's a 2-in-1 corneal forceps, 0.2 millimeters. The model number is F109. It was previously an Einor make, but I think now the Epsilon people make it. So that forceps is you need to have a good forceps.
Dr.
In
Boramani,
case somebody is not using the superior rectus suture, Dr. Boramani or Dr. Amulya Sahu will say and will vouch by that actually we have done away with the superior rectus suture treatment.
Yes, Dr. Boramani.
Yeah, I have a few comments. As Dr. Debashish rightly said, for the dissection, you have to keep the curvature of the globe in the mind. Many times a beginner, they just keep moving the blade in a horizontal fashion, but you have to go in a curved fashion, and the nasally, the globe is more curved, so that you have to keep it always in the mind. Secondly, I don't remember whether the speaker told about this because in between I got a phone call. The globe should be well pressurized. When the globe is well pressurized, either with AC maintainer or viscoelastics, then the walls of the sclera are properly stretched, and then the dissection becomes easier. Like if you want to cut a cloth, you always stretch the cloth and then pass the scissor. So similarly, when the walls of the sclera are stretched, then dissection becomes easier. And especially when you're doing the wet lab in goat side, this is forgotten because the goat side, they become very flaccid. So you have to inject some fluid or viscoelastic, make the wall very taut, then the dissection becomes very easy. And third observation is that now we should stop taking the bridal suture, superior rectus suture, because in olden days there were no good speculums. Now we have got very thin, lightweight speculums. The retraction is quite good. So superior rectus suture is an unnecessary trauma to the eye. It is not required at all.
Do you all have Satyajit? Would you want to take a question? Satyajit?
We'll go ahead, ma'am.
There is one other question I have. When we are talking so much of tunnels and all, since would you believe there is any role of a guarded knife which will exactly define the depth of the process? It's not commonly being used at all. I just wanted to ask that question.
Yeah, I mean, you should be doing 1/3 of the incision. So, I mean, say about 200 micron guarded knife would be perfect. But as I told you, and as Dr. Boramani also emphasized, that you have to keep in mind that the top of the globe, that is the middle part of the incision, and is more curved than the periphery. And usually we tend to be shy on the periphery, and same pressure, we will get a deeper incision in this. So obviously a guarded knife helps in this direction, but there aren't any in the market. And I think most of the surgeons learn it by themselves. And so that is the situation. But yes, I mean, the recommendation is well taken. The other thing, Chitra, I would like to make, is because we are right-handed persons. So essentially, the center of the incision, because we have this carrying angle, and the lady surgeons have more of that. So, the vectis or any instrument will go a little diagonally into the incision. So the incision has to have a off-right center, meaning if you are doing a superior incision, it should be 12 o'clock, but it should be more towards the 11 o'clock. I think I was clear on that.
Dr. Chitra, I want to make a comment. There are guarded knife available with shrinkage. I have used quite a lot of them, and I found it very useful in some cases. So although we use a bar Parker knife, 15 number blade for making the incision. And as you all know that the surgery of any kind in cataract surgery, as is mentioned in Stallart's book, textbook of surgery, they say that as goes the incision, so goes the surgery. So incision is very important. Only thing one more thing I would like to add is that if you are making a temporal incision, you have to be slightly closer to the limbus in comparison to what you make in the superior aspect. That's all I wanted to make.
Yes. Should we move on to the next talk? Dr. Boramani, you have one point? We can.
Yeah, to make one point.
Yeah.
See, incision is the heart of the SICS surgery, and it is the incision where it differs from phacoemulsification, incision and the nuclear delivery. Now we have talked about how to learn. So in how to learn, I want to add one more thing. Now this SICS simulator training is available in India with help of ISM, SICS and HMS. It is always available in our CCC conferences. A center is there in Mumbai. One more center started in Pune. Very soon there will be a center in Guwahati. So before even touching the goat's eye also, I think this virtual experience is a real life experience. And even if the teachers train their students for training, many times the teachers are reluctant because there is a manpower loss. 1 week, the student will be away from the hospital. But if a beginner learns on the simulator, it saves a lot of time of the teachers in the training because they become almost partially expert in doing the human eye. So everyone should take the benefit of SICS simulator training.
Okay.
A few comments I observation of mine. Now this videos were, as I saw, I think the learner's video, but the teacher has taken the right correction there. And I saw somewhere they have given a smile incision, which should not be done. Second thing is that from limbus 2 millimeter should be avoided because the maneuverability becomes difficult. So those are the things, but otherwise the teacher was correcting those things. If a premature entry is there, how to manage it, all those things. What is a very learning video for beginners. So that much I want to say. And the other things I think, but Devasis and Varamani, they have covered it very well. Thank you.
That was a wonderful video, Tamil, and
Dr. Chitra, can I just make a small comment in addition to all points are very well taken.
Yeah.
One or two points is when she was holding forceps, she was holding in different areas every time she was manipulating. She came back. It's better to identify the most, ergonomically correct position and relatively avascular position. She was holding right at the limbus, which is the right place. Many people hold it far away, and at the limbus, the conjunctiva, tenons, and sclera are firmly adherent to each other. So you should hold it very close to limbus, and hold it at the same place every time. And as Dr. Debashish said, it has to hold the sclera, not the conjunctiva. The teeth should be protruding like teeth of a mouse, and it should hold the sclera so you get good stability. I would suggest everybody to start from temporal side instead of going from the superior side. It's very easy to shift over or start from temporal side. Third is the crescent blade itself is too long. When you are going there, there's a lot of additional length is there which will hurt the lids, which keep touching the lids, and patient will have sensations of the heel of the tunnel blade touching the lid, which can be avoided by selecting a tunnel dissector, which is shorter in length. And the most important thing to get a good suction is neither the forceps nor the blade should be either dragging the tissues up or to push the tissues down. They should keep respect the normal anatomy, circular globe-like anatomy of the eye without any compression or elevation, and both the eyes come into picture. Then if you do that, and your plane should be uniform. The last point is the sharpness of the blade, which is very, very critical. I would appreciate the younger people who are starting should not go for a very, very sharp blades, new blades. They should not go with it because sharp blades will find out their own way of getting wherever they want. If the blades are, say, 2-3 times autoclaved and you pick it up, and they respect the tissue planes much better than very sharp blades.
Yes, thank you very much. Dr. Ragini has not joined in yet. She was not keeping well. And but it's a very important topic which she had to talk. That was on rhexis extension and Argentinian flag sign, what next? So although I do not know the content of a video, I just want 2-3 questions to be asked so that I do want our attendees to learn something. Now, when you all are starting to teach your trainees an SICS surgery, do you all teach them to start the rhexis straight away, or do you all start with a can opener technique and then move on to the next step? I mean, I would want to know about that. Yes, Doctor.
Chitra, The envelope capsulotomy is a wonderful incision.
Yes.
It's very popular in Lahan. It's called the Lahan capsulotomy also. Essentially, with the keratome, you straight go in and make an incision on the lens, and then make 2 snipes with Vanus scissors on either side, and then hold the rexis, hold the capsulotomy and tear it off. The other capsulotomy that one needs to learn is obviously the can opener capsulotomy. Like in SICs, it is not mandatory that you need to do a rexis. But with a beginner, what is important that if you have frills of these anterior capsules lying somewhere, it would be very difficult even for experienced surgeon to identify those areas. And when you are clearing the cortex, you would unnecessarily pull on those tags and create a TC rupture. So that is the thing which actually that's where the benefit of rexis comes. So essentially, yes, I think to start with, if a surgeon is giving a too small rexis and all that, to boost his confidence, one can try to give him 1 or 2 can opener capsulotomies, but the idea would be to convert to a rexis and as early as they can do.
The other question which I have is, if you have decided to do a rexis again in the training period, would you like to go to the main incision or would you like to go to the side port as we do in phacoemulsification? What would
I
be
think
the
Chitra going through the side port would be, they would be tied
Yes.
for space.
Yes.
And, you know, because they are learners, so it will be restricting their dexterity. So I would say, you know, they should go through the main incision. If required, we can give them some good viscoelastic so that, you know, they have a well-formed chamber. But the key to it, again, is, as Dr. Ravindra said, that, you know, you don't never press the globe. You pull the globe with the forceps. So, and you, the incision that we have created is a self-sealing incision. And whenever we lift an instrument on the upper lip, like the rexis forceps, if we rest it on the upper lip, then the incision is automatically closed. So we have to get it into their minds that please lift the upper, rest the forceps on the upper lip, the incision will be closed, the visco won't leak, the chamber will be well formed, and you can continue with your rexis. Small turns, grasp and regrasp and get a big rexis. And just in case one has done a small rexis, then multiple release of the rexis has to be done with a bent capsulotomy needle so that they can be comfortable prolapsing the nucleus out of the
Dr. Ravindra, if there has been a compromise in your making the rexis, then what would be the subsequent precautions which you would advise an SICS surgeon?
Yeah, the rexis should be of adequate size, and many times we land in problems because we create a disproportionately sized rexis when compared to the hardness of the nucleus. The student learner has to actually grade the nucleus and pre-plan the size of the rexis. One of the good option you have to plan, if you can't do a circular rexis, plan for an oval rexis. You go to the periphery and come back, and go to the periphery and come back. So you'll have a hole like a button hole of your shirt. It will be oval in shape, and that will remove with that you can remove the nucleus. If you have ended with the rexis which is smaller, and if you cannot manage
rexis,
huh?
if it's extended,
It's extended. Extension of rexis, I think immediately the senior has to take over. The student should not continuing with that. And there are many ways of handling it through the main tunnel. You create another from intact area. You start another rexis either with a cystotome. Cystotome, if you cannot cut the rexis margin even with cystotome, puncture it about 0.5 millimeter peripheral to the rexis, and you'll be able to start a new rhexis from the other side, or use vanas and or micro vanas and continue the rhexis. But do not attempt to remove the nucleus if the rhexis is too small.
Yes, Dr. Boramani.
Yeah, when the rhexis goes to the periphery, there are 2-3 methods which have been advocated. The beginner should hand over to the expert if it starts going to the periphery. But there is one method I would like to suggest, which is not generally described in any conference. The extension of the periphery is difficult to bring in the center because there is always a centrifugal force because of the stretched zonules. So if you relax the zonules by creating a dimple on the globe in the ciliary body region, so with lens hook or any instrument, just wherever the rhexis has gone to periphery, in that meridian, you try to press the ciliary body region. That relaxes the zonium to a great extent, and that will nullify the centrifugal force, and that it becomes comparatively easy to bring that peripheral rhexis again in the inside.
Okay, right. Any other question? Any expert panel we want to add? Dr. Satyajit, you want to add something before we go on to our next speaker?
No, ma'am, we can go on to the next speaker.
Okay, so our next speaker is Dr. Supriya Singh from Kolkata, and an extremely prolific, capable surgeon and senior consultant at the Eye Care Center in the city center. And she was going to tell us something more challenging, like it's a small pupil situation now and how she would proceed. On to you, Dr. Supriya.
Thank you so much, ma'am, and good evening, everyone. I'll be discussing about the management of small pupil in SICs. There is no set numerical definition of small pupil, and it is completely subjective. The size of the pupil for performing a comfortable cataract surgery depends upon the grade of the cataract, skill of the surgeon, and other associated comorbidities like pseudoexfoliation, eye frills, corneal scar, posterior synechial, etc. So, for me, the definition of small pupil is any pupil size or cataract surgery.
Can everybody mute themselves?
No. In this patient, although the pupil size is just 5 millimeters, but since the cataract is soft, so it can be easily managed without any additional maneuver, and this does not count as a small pupil for me. Whereas this patient of corneal opacity and adherent glaucoma, because of the corneal opacity, the view in this patient is limited, and so even a 7 millimeter size pupil will also count as a small pupil. Now, the 3 most important factors which I consider while operating in cases of small pupil are appropriate capsular staining, adequate capsulorhexis, and sufficient hydrodissection. For capsular staining, I employ the technique of capsular painting as described by Dr. Kokar. In this, the anterior chamber is filled with either HPMC or 1.4% Helon GV. The tip of the cannula is placed just below the pupillary margin, and dye is released while making a sideways sweeping movement. This way, dye is released onto the anterior capsule, and it ensures uniform staining of the anterior capsule, including the portions peripheral to the pupillary margin, as can be seen here. I usually aim for a slightly larger rhexis, approximately 6.5 to 7 millimeters, depending upon the grade of the cataract. And I spend few extra seconds to make sure there is good hydrodissection, as if we do these 2 steps properly, it saves many complications like PCR, zonular dialysis, and vitreous loss. But doing a good rhexis and hydro might be difficult sometimes in small pupils, so various techniques are employed for pupillary dilatation. The first among such is use of adrenaline. I prefer to use intracameral adrenaline. Some surgeons use high molecular weight viscoelastics like Helon 5, but I prefer to use the usual HPMC, and most of the cases dilate with simple adrenaline and viscoelastic. In cases of posterior synechial, a synechulysis is done, and if there is a membrane, then even using manual methods, membranectomy is done. And once again, in most of the cases with synechulysis and with the use of the adrenaline, pupils dilate. For obstinate pupils, more aggressive measures are employed, such as stretch pupilloplasty. In this, 2 instruments are placed to stretch the pupil at diametrically opposite points. Usually Kugelin hooks are used, but one can also use dialers or sometimes chopper if Kugelin hooks are not available. Another technique is the use of syncrotomy, in which multiple tiny cuts are made in the iris. Care must be taken not to cross the collarate while cutting the iris. The subincisional pupil can be easily approached through the side port. Now, both sphincterotomy and trabeculoplasty are quite inexpensive and easy procedures, quick procedures, and therefore they are more frequently used in SICs, especially in camp surgery. But there are some specific scenarios where hooks and rings are more useful. Like in this patient had spheroidal degeneration of cornea and pseudoexfoliation, so I decided to use hooks for better visibility. Now, while using the hooks, care must be taken not to overstretch the pupil, as it may damage the sphincter permanently. This is another one-eyed patient who had complicated cataracts secondary to uveitis, and I decided to use rings, as rings are less traumatic. Most of the times, as soon as hydro is done, I remove the pupil expanding devices, but there are some expansions, like if pupil is extremely small, and in cases of zonular dialysis, I prefer to keep it until the end of the surgery. Now, this is one particular case where the rhexis was done, and after completing the rhexis, I realized that it was very small. Since I have done a sphincterotomy, it was difficult to put rings or hooks. So therefore, I made some small nicks in the anterior capsule for safe delivery of the nucleus. To conclude, do not compromise on the size of the rhexis and good hydrodissection. Do not hesitate to use different techniques of pupillary dilatation. Thank you so much.
That was a wonderful presentation, Dr. Supriya, and I really introduce you. You are from one of the most major assets for Dr. Debashish Bhattacharya from Disha Eye Hospital. So I'm sorry for not having introduced you adequately, and that were amazing set of surgeries which you showed. So let's go on to the discussion. Like many of the cases which she had shown, I'm generally referring to all the expert panel. If it is a phaco surgery, I would have thought of using an iris hoop primarily. But those challenges are less in a SICs. So would you, if you are asked to choose between one of them, would you do a stretch pupilloplasty? Would you do a sphincterotomy? Or would many of you use iris hoops in most cases?
A pupil expander, Chitra, is a question.
Yeah.
Because here, you need to take it out. So
Yeah.
iris hooks for the beginners are is the thing that has to be used. Now, Dr. MS, I've seen him, and even I also do at times. Yeah, we can do a big rhexis under the pupil, but that is all imaginary.
Yes.
What Supriya stressed, and that is very important, that the incision on the lens, that is the capsulorhexis, has to be adequate for the nuclear size.
Yeah.
Any disproportion, and we try to bring the nucleus out, I mean, there will be zonular dehiscence. So this thing has to be kept in mind. This is the most important thing that has to be kept in mind. So, like, if we are seeing, and one thing like the experienced surgeons do is to drag the nucleus so that the equator is visible in the pupillary or near the pupillary area, and then give a little pressure so that the equator of the lens nucleus is out of in the pupillary plane. Once you get that situation, you can walk on the equator of the lens with two coplens, and then it actually usually just rolls out of into the anterior chamber. But the multiple release of the the rhexis, if we should not be using unnecessary forces to prolapse the nucleus into the bag, we should assume that the rhexis is inadequate to the size of the nucleus. And obviously, the use of the iris hooks for the less experienced surgeon is a mandatory.
Yeah. Anybody has anything else to add?
I think the SICs, the sphincterectomy will be a better option instead of having multiple incision in the cornea. So this will be a better option because ultimately we are going to give good vision. Aesthetics can be have a second period.
Okay.
Dr. Chitra, I just wanted to say one thing, that
Yeah.
a good examination in a case of complicated cataract because of uveitis is very important. And one must see where the synechiae are there, whether there is any fibrous membrane there or not. Many a times, if you simply remove that membrane from the pupillary margin, the pupil will dilate. That many a time we miss because we have not examined the patient under slit lamp. So that is one aspect that one should take care of. The other important thing is, as iris hooks are very, very handy and you can use that. And one should not forget to give oral steroids because it should be done under cover of steroids if there is uveitis. Many a time these days we are straight away going to the OT and operating them, and steroids are not given, and post-operatively suddenly we get a severe attack of uveitis. So these two things are important. Otherwise, rest of the things have been told by the others.
Yeah. Before we move on, one last challenging moment for small pupil. Supposing you had a PCR in a small pupil and the iris is also mildly traumatized, what would you do? Would you still stick to an iris IOL, or would you look at IOL, or would you think of doing a sclerotomy? I just want to understand whether the approaches are going to be different in an SIC as against SECO. Am I heard?
No, lot of disturbance was coming.
Yeah. Did you get my question? If there is a PCR in a small
Yeah, Chitra, we got your question. The thing is, everything should be visible. Like you see that with a small pupil, you have done something and now there's vitreous in the anterior chamber. I think the first thing we need to do is, as Dr. Sahu said, well, sphincterotomies. Well, I have my reservations for sphincterotomies because you are going to enlarge the pupil, and if it is a relatively young patient, then not a very comfortable post-operative situation. So we have to get in with hooks. Now, once we've seen, we have to understand where is the PCR and the extent of it. What is the capsular rim which is left? I mean, is it intact or is it compromised in one or two places? Then we can actually place a lens in the sulcus. That is not a big deal. And we can do vitrectomy, clear everything, see that everything is clear, and then put in a intraocular lens. I think PCR management with SICs is much better because we don't have to deal with, even if there is a big nuclear fragment, we need to get bothered, because which in phacoemulsification, it is the time when we convert to SICs. So essentially with the PCR in a compromised situation and compromised eyes like the small pupils, I think we need to see properly and act. So if everything is all right, I mean, why not a lens in the sulcus? We can always give. And for that reason, we have to keep multi-piece lenses in our theater. And some also give hydrophilic single-piece lenses in the sulcus, which are forgiving, I'm told, but never a hydrophobic lens in the sulcus. Yes.
Okay. Mr. Sunil, there is some noise.
Dr. Chitra, I just wanted to say that in case you have a PCR, you must apply a suture immediately. And if you find that the vitreous has come into the anterior chamber, then one must do a good vitrectomy and then go ahead with this. So applying a suture is very important. Many a times it will go with vitrectomy, and the chances of choroidals are there. So one should apply sutures and do vitrectomy, and then should go ahead with the rest of the procedure.
Yes. Any other important point which needs to be covered?
Dr. Chitrak may add one
Dr.
point here.
Kamaljeet, I understand that there's a network issue at your end. I actually switched off my video. Maybe you should not move your
Yes.
phone. No. Yes. No.
Dr. Chitra, I have one point here. Can I say?
Yes, sir.
Fine. We looked at our endothelial count with adrenaline, and if adrenaline is introduced into the anterior chamber with before injection of the viscoelastic, the endothelial loss will be very high. And so you coat the endothelium with viscoelastic and then only inject adrenaline very close to the pupil. So you have that distance, respectful distance away from this. And the dilution, we worked on different dilutions. The dilution of 1:20, 1:20 of the adrenaline ampule is the least traumatic to the endothelium. So I would suggest somebody who is using adrenaline should inject it close to pupil and dilute it 1:20. That also works, and very little quantity of adrenaline is good enough.
Yeah.
The second thing is, ever since we have shifted to topical, whenever there is a mismatch between the rhexis and the size of the nucleus, the only thing patient feels is when you are prolapsing the nucleus from the intracapsular to anterior chamber, if the patient complains of pain, that means you're actually stretching the zonules. That's the only thing which is painful. When you're in the maneuver, the rhexis is small, and when you're given a retrobulbar, you will not feel this, but on a topical, when the moment pain is there, it means that, especially in a small situation where you're not seeing the capsular bag, if the patient complains of pain, that means there is a mismatch and you'll have to stop, put the lens back, enlarge the rhexis, and then only remove the nucleus.
Yes, two very valid points and really important for us to keep in mind. Should we go on to our next speaker? We did have a lot of extra time because very sadly, Dr. Ragini was not there with us. So I could take one more important point to be discussed, if any, before we go on.
Instead
And
of
the role of BHEX in small pupil?
Yes.
No,
Satyaji?
no.
Yeah.
Any pupil
BHEX
supporting device, the device which is taking the support of pupil is a big no in SICs because that hampers the nucleus management. For phaco, it's all right, but for SICs, no, like the pupil expanders which are supported on the pupil, they hamper the nuclear delivery.
Once you have made the rhexis, you could remove it and then the nucleus can be delivered. Will it help in making a good rhexis if you have, because in the last video that we saw, most of the rhexis appeared to be like a blind procedure because the surgeon was experienced. But if we had a pupil expander, we could have at least known that the rhexis has been made properly. And then I agree with you, the expander can be removed and then the nucleus can be delivered.
Yes.
See,
Deepak,
Satyajit,
Deepak,
I
any
think
thoughts on that?
I would go with Dr. Boramani, and iris hooks are the things to go to expand the pupil, because you put a thing again, take it out just for getting a good rhexis. I think that's not the way of
Waste of time.
it's done.
No, I think Satyajit wanted us to think of all probabilities. So what comes across clearly that either you do a sphincterotomy or a stretch pupiloplasty, you can get away with these things in SICs because you are not further challenged by the phaco-dynamics and a floppy iris kind of a situation. And you need to have a larger rhexis, as large as is feasible, as beautifully is told by Dr. Supriya. And of course, going on to the further
But at the end of the day, it's always helpful to have the IOL in the bag. And if you have a proper rhexis, then things are much more.
Can I make a statement here? Can I make a statement here?
Yes,
Please.
yes.
In SICs, nucleus itself acts as a pupil expander when you take it out through the pupil. That also acts as a pupil expander.
Yeah. Yes.
If you can pull the iris that is pupil towards yourself and nudge the nucleus out, it will automatically comes out in a small. But beginner, it is not the right.
Not right.
It's a small pupil. You have to make a big rhexis because you are doing SICs. You have to deliver the nucleus.
Yes.
So at the end of the day, it always becomes a blind procedure when you are doing a rhexis.
Absolutely.
If you want a good rexis. So
It is, for beginner, the other approach has to be done. You know, they should see and do.
Yeah,
Experienced people can
Satyajit,
do.
we definitely get the point that you are trying to make, and definitely pupil expander will show me the way how I have done the rexis and will help me do that. And but I mean, if you compare the price of a pupil expander versus the Madhu Irish hooks, I think the Irish hooks are
Yes.
inexpensive and they work throughout the procedure. So I think I'll always go by the Irish hooks.
we'll move on, man.
Dr. Deepak wants to say something.
Yes, Dr.
Oh, sorry. Deepak wanted.
No, I think the most of the products, most of the things have been covered. My thing was small pupils sometimes are associated with pseudoexfoliation. We have a generalized zonular weakness as well. So many times it's just not about delivering the nucleus out. We may have to see to ensure the CTR is put in, the cortex aspiration has been done properly. For all these situations, you need to see well, and iris hooks are still the best bet when doing SICs with pseudoexfoliation in small pupil. So it's not about just dealing with the small pupil. There are coexisting morbidities like weak zonus, and many times the bag comes out when you're trying to do cortex aspiration itself. So we need to be careful until the end of the thing. So iris hooks still are the best bet because we can see well, and they help us to introduce the CTR as well. So CTR does have a role to play in many of these cases. So I think that's the way.
Yeah, very relevant. And so that we shall now go on to our next speaker, Dr. Deepak Meghur. I'm always with these all the kind of videos which you see on the YouTube and on in the different webinars. Would it be enough to call him a prolific surgeon, a versatile surgeon, an immensely capable surgeon? It really beats me. And he's heads the Meghur Eye Care Center and is with the extra interest in cataract, glaucoma, and complex cataract surgeries, and has also a very keen interest in angle closure glaucoma. And he's going to take us through a different terrain. From small pupil, we are now going to delve into cataract surgeries in eyes with corneal opacities in SICs, with SICs. So let's hear from him. On to you, Dr. Deepak.
Thank you, ma'am. Thank you for the introduction. Thank you for the opportunity. Dr. Debashish sir just mentioned that, seeing well is the essence of surgery. We need to ensure that we see well for the surgery to go on in an uneventful manner. And that's the challenge in these corneal opacities because the visibility is severely compromised. And are there any ways by which we can improve visualization during surgery? That is going to be the focus. One way is to play with the light source and the angle of illumination if we can. So nowadays, the most simple way to do is the inbuilt stereocoaxial illumination of microscopes, which the modern microscopes have, like the Lumera I and the Leica variants. They have the inbuilt stereocoaxial illumination, and that really dramatically changes the way we see things. Initially, we were using oblique illumination with an external light source, like an endoilluminator held at the limbus across, or a torchlight held at the limbus, and these all can be moved around and they can help us to see well. And the last one is obviously, the newer way of illumination is illumination from behind, that is using endoilluminator like the Chandler's illumination through the vitreous cavity. Even that gives us excellent visualization. And the biggest challenge, as I tell you, was the visualization. There are ways by which we can play around with the incisions, ensure that we have a clearer area where most of the maneuvers can be done. And these things have been planned on individual case basis because the situation, the location of the corneal opacity might vary from patient to patient. So that is something which we need to look and plan. And if we don't see well, that's the most common reason why complications can happen. So I think we need to be, take a little bit of a more time. And this is how the same case looks with an inbuilt stereocoaxial illumination. So that's the importance which I was highlighting, that, you having a different source of illumination than a traditional microscope will definitely help us to see things better. So it does play a role for having this. Now, if somebody has an older microscope, we can switch on something like this device called as the OmniGlow and many similar devices. This was devised by Dr. Kakadia, and is just an attachment wherein go and fix into the microscope. This is an old Zeiss F1 Pro, and by just adding this illumination source, you get that enhanced red reflex. So that really helps us in some complex cases like small pupil and the ones with corneal opacity, where visualization is a problem. Now, this is how it is. Now, this is the area of opacity, and this is where we have to plan to work. So most of the instrumentation has to be visualized through this. And incision location, again, depends upon the where the opacity is. And obviously, staining of the anterior capsule and using good viscoelastics do help to protect the endothelium and to help in better visualization. Even the cataract is immature, still staining helps a lot. And putting dollops of this HPMC over the cornea very frequently, it enhances the visualization, at least momentarily, and also magnifies the view so that we can see well. Repeated injection or putting the HPMC over the cornea does help. Now, this is an elderly lady. She's one-eyed, having black cataract and with dense corneal opacity. It's an adherent glaucoma-like picture. And also she has got pathological myopia. Now, this is a situation where we need to plan surgery. In these cases, I think the manual small incision cataract surgery is the best bet because we've got multiple challenges to deal with. Apart from visualization, we have got coexisting difficulties like, small pupil, adherent glaucoma, and synechian compromised endothelium. So how do we plan this incision? The incision is planned in this is a case where I'm sitting superiorly. This is a superior incision because the glaucoma was at the inferior medial end, and there is no compromise with the incision here because the concept is very clear. We want to be as automatic as far as possible during nucleus delivery. So I'm not intending to crack the nucleus in any way, just to get the entire nucleus in a single plane. So I'm making maybe a 7 millimeter or 7.5 millimeter large sclerocorneal tunnel incision, trying to stain the capsule. Once I stain the capsule, I can see that the capsule is also fibrotic in areas because of the long-standing nature. The thing is, whenever we are having this opacity, the trick is to, once we make a nick in the capsule and try to grasp the flap, so I'm trying to just release the iris from the attachment to the back of the cornea, that is the adherent glaucoma. I'm just using a micro scissors to just relieve it, trying to work around the area of the fibrosis. So once I get hold of the flap, usually the rule is not to leave the flap until the opacity area is taken care of. But unfortunately, I lose the grip here. But nevertheless, I was lucky enough to just go back and grasp the flap once again and create the rhexis. The secret is try not to leave the flap during that area where the opacity is there. So I'm mindful that the cataract is going to be very large. So I'm trying to enlarge the rhexis here. Very slow and minimal hydrodissection is done because this is a very big nucleus with hardly any epinucleus and cortex, and the posterior capsule will also be very thin and fragile. We need to be careful about that. I'm using sodium hyaluronate to keep the chamber formed here. I'm using two Sinskey hooks to nudge the nucleus to the periphery, engage the equator of the nucleus, and then bimanually dial the nucleus, the nucleus out of the capsular bag into the antechamber. So although this area is not visible because of the opacity, I'm still able to visualize it in the other part. Again, care is taken to create some space between the nucleus and the iris and the endothelium. I'm using the standard phaco sandwich technique with the vectis and the dialer, and it is pulled out effortlessly. So the essence basically here is that, you want to be as automatic as possible, be very liberal with your incision and the rhexis so that the nucleus delivery is going to be very automatic. One can use the Simcoe cannula for cortex aspiration as well. I'm using a bimanual irrigation aspiration. Again, the retroillumination mode is turned on so that the visibility is much better now, because once the cataract is out, we can see things well. Again, the area under the opacity is going to be very tricky. I'm just trying to maybe retract the iris with my second instrument and try to pull out some of the cortex, which is possible for me to remove. Again, it's going to take some time. I'm going to irrigate some saline just to loosen up the cortex. And once the intraocular lens is placed, I'm going to use a suture here to ensure that the astigmatism is under control. Although because of opacity, we don't have a control of the cylinder which is going to be there. So I'm going to use the foldable intraocular lens into the bag, and care is taken that ensure that both the haptics are going into the capsular bag. And this is the part of the iris which I want to cut, just to ensure that the light can pass through this inferior nasal quadrant. It's a sort of an modified optical iridectomy, just to help for better visualization. And that's it. I think if you can plan the surgery well and take all the adequate precautions, most of the times we tend to have good outcomes for this. Of course, the vision cannot be compared with that of an eye with a healthy eye, but it's functional in most parts, and the patient do enjoy a good visual outcome, which will help with the thing. The last one, using a chandelier illumination. This is a film which I borrowed from Dr. Rusha Shroff, and they have made this wonderful film where they demonstrated the use of the chandelier illumination to be placed through the pars plana, and the illumination is what it provides is amazing, basically, so just illuminating the vitreous cavity and the retroillumination which you get from that, it is just quite amazing. And this is how the view will be there with the retroillumination from the endoilluminator through the pars plana, that is the chandelier illumination. And with this, the illumination is truly remarkable, and you can manage it pretty well in much more safer way. Obviously, they're demonstrating phacoemulsification, but nevertheless, it is something which we need to know. So that was it. Thank you for your attention.
Thank you. Thank you so much, Dr. Deepak. You brought out all the salient points, and some of the questions got swallowed in the process. I'm going to ask you the questions, and I would want thoughts of the expert panel too. Now, does it make sense to do, you had shown a beautiful case of doing an optical iridectomy. Now, do you need in majority of these eyes, which a lot of opacities, and then you have decided to do an SICs and a hard cataract, would optical iridectomy become quite a routine step? Or would you, now the way modern corneal surgeries are, would you look at doing a corneal procedure following that?
Yeah, there's an option depending upon the status of the corneal opacity. It was a vascularized corneal opacity and an elderly patient, and I don't think most of the corneal surgeons would be willing to perform any corneal surgery. But if there is an opportunity to perform, if the corneal opacity is not dense, not vascularized, and the visual outcomes are better with the corneal procedure, then why not? We can consider that as well.
Yeah. And in such cases, invariably your K would be taken from the opposite eye measurement, right?
Yeah.
Yeah.
Absolutely.
And the other question is that if there is a severe corneal opacity at the patient, I think Dr. Kamaldev, you should switch off your video.
Hello, are you asking from me?
No, you have to switch off your video because there's a noise coming from your end.
From my end?
Yeah, that's what Mr. Sunil is saying. Only switch out the video. We want the audio of yours. We'll just try it. Yes. And
I am muted.
oh, no, don't be muted. You can be on. The other important thing I wanted to ask was, like, if there is a severe corneal opacity and the patient has a past history of viral keratitis, how would you treat these patients?
I think it's important to realize that the viral, the infection is not active, first of all. We need to take care of this. So if there's an inactive lesion, there is no active infection or inflammation, then we plan the surgery. If there is an active viral disease, either in the form of infective epithelial keratitis or a stromal inflammation, then those things need to be addressed before taking the patient for surgery.
Anything which others have to add, including Dr. John Sarkar, anybody? If you have anything to add.
Yes, ma'am. Am I audible, ma'am?
Yes, you're audible.
Yeah, this type of, I think, well, ma'am, this is a nice question. First of all, if it is a one-eyed patient, and had a history of HSV keratitis, we should be inquire about these things. The patient, there should not be activation for last 3 months, more or less. If the patient first time came to us, I didn't know the patient about these things. They come for the only cataract surgery. Being a corneal person, what I usually follow, I don't jump for the surgery. I just wait for 1 month more, as they already had the one-eyed patient and had a history, quite suspected HSV. So we should not jump for the surgery for the cataract surgery for the immediately. At least 1 month wait for that. If there is no reactivation, and then we are doing this type of had a history of HSV keratitis under the coverage of a oral acyclovir, and it should be started 400 milligram, preferably twice in a day, 7 days prior to the surgery, and is a close monitoring and while we're giving the steroid immediate post-op periods. And if it is needed, then we can carry on the things at least for the 1 month post-operatively, and it should be closely monitoring the patient. It is not that that epithelial lesion activation. I should be quiet, because any stimulation, even also the patient with mental stress also, there is a high chance of HSV stimulation is there. So especially we should be much more cautious whenever we are operating for this type of patients. And one thing, if it is one-eyed patient, ma'am, you were uttering that we have to take the, if the patient has the scar, this type of scar regarding the biometry, we are taking the axial length of that eye and carrying from the other eye. Suppose if the patient, exactly, and if the patient is a one-eyed patient, in those cases, then we don't have the option. In those cases, we are taking the axial length of that eye and the standard K1, 40 by 40 of that eye. And then we get the predictable outcome of the post-operatively.
Very good, very good. You brought out all those extra small nuances which you wanted to have. Anything else from our expert panel?
Dr. Deepak has done a wonderful surgery. Actually, from the very beginning, he was very careful that he made a large incision. And it was quite large, and therefore he applied a suture also. So that was wonderful. And that point should be taken care of by all the beginners and even experienced surgeons. That is what I wanted to say.
Thank you, Dr. Kamalji.
Dr. Chitra, I have 1 or 2 points. Can I say now?
Yes, sure.
Excellent, as usual, Dr. Deepak. Nothing short of the video that we would expect from you. 2-3 points. What you did was iris additions to the cornea release with micro scissors. That's a wonderful step. And I think any additions where it's bringing the iris forward has to be released during cataract surgery, wherever it is. 2 things will happen. Along with the iris, many times capsular bag also will be lifted up. That will prevent the slanting of the IOL when you put the capsular bag, when you put the lens inside the capsular bag. The second is these synechiae after surgery, because the inflammation can progress laterally like a zipper, and they can close the PAS can extend after surgery. It will totally avoid PAS happening, and secondary glaucoma post-operatively also will be avoided. Second is you would have done it, but then it was not visible in the video. How did you remove the cortex under the opacity? So what I would prefer is all the cortex in whatever situations we are in the cataract surgery needs to be removed. And after removing the cortex in the periphery, in the visible area, the same amount of effort, same amount of this thing, especially with the Simcoe cannula, if you go under the opacity, you will be able to remove the cortex. The other option, you would have done it, but the other option is to rotate the lens in the capsular bag so that the haptic itself will loosen some amount of cortex and that get released into the anterior chamber, which you can aspirate. So these are a couple of points I would like to say. And in such situations, it's always nice to have a preoperative photograph along with you. And it actually shows, see, when you dilate people, the pupil is dilated. Sometimes post-operatively, we see that there is hardly any slit available between the opacity and the edge of the pupil. So if we have a photograph on the table, you can actually would know how much of sphincterotomy you have done. I would have rather done sphincterotomy inferiorly at 6 o'clock or whatever it is, instead of temporarily where you're doing it under the opacity. So that opens up a little bit of pupil in the pupillar area. I do not know how the patient was post-operatively. You can comment on that.
Yes, Dr. Deepak?
No, I did in the inferior medial quadrant, sir. It was not in the temporal. It's in the inferior medial quadrant. The opacity was extending all the way up to 6 o'clock, from the center to the 6 o'clock. And there was a small area of clear cornea in the inferior nasal quadrant. So the inferior nasal quadrant was where the iris was cut.
Okay. Thank you. Thank you. Do stay with us, Dr. Deepak. We want to have your expert opinions too. We shall now go on to our next speaker, Dr. Santosh Bide, and has a leading practice in Pune. And more importantly, he's a very eminent person in Maharashtra Society and in the national level, and a very prominent role in ISMICS. And we look forward to learning from him on another very important topic, phacomorphic and phacolytic glaucoma, ideal way to deal. On to you, Dr. Santosh. Can you?
Thank you.
Maybe, no, we can't.
Am I audible?
Now you're audible, but there is a network issue. Maybe while presenting, you could switch off your video and see.
We can't hear him.
Dr. Santosh?
He is disconnected, ma'am.
Is disconnected?
Yes, ma'am.
I think he'll connect again.
Could you call him, Dr. Satyajit?
Yes.
Should we go on to our next speaker and come back to Dr.
I think he is
Santosh?
just connected, ma'am. I think he is connected, ma'am.
It's connected.
He's connected.
Achha, dekh liya.
Hello, am I audible now?
Yes, you're audible.
Hello.
Yes, you're audible.
Is it better now?
It's better now.
Is it better?
Yes, better.
Yes, Santosh, we can hear you.
Okay, so yeah, okay, thank you. So I'd like to thank Chitra and Team ARS for giving me an opportunity to share my thoughts on this important topic of phacomorphic and phacolytic glaucoma. I can't see my presentation. Can you see my presentation?
No.
Not yet. You need to share your screen. Sunil ji, unko help karo.
Yeah, please done, sir. Can you see my presentation now?
No.
Not yet.
It is yet to come. Hello.
It's coming up, coming up.
Is it seen now?
Yes.
Yes. Yes.
Can you see my presentation? Hello.
Yeah.
Yes, we can see
Yes.
your presentation.
But we can barely hear you.
Shall I join again after some time?
That may be a good idea. Ma'am, we can move on to the next speaker, ma'am.
Yeah. Yes, we can. We shall now go on to our next speaker, Dr. John Sarkar, who is practicing at Shushruth Eye Foundation and Research Center, Calcutta. Again, a very dynamic cataract surgeon, and he is going to lead us through combined surgeries. That is when a pterygium is also present, and with a conjunctival autograft, and his practical tips in how he protects the conjunctiva, doing an SICs, and also taking care of the pterygium.
Am I audible, ma'am?
You're audible, but you have to share your screen, I think.
I have shared, ma'am.
Dr. John is coming gray.
1 minute, sir. 1 minute, sir.
You stop sharing and share again.
Dr. John, first open your presentation and then do the screen sharing.
Yes.
It's coming.
Yes.
It's coming now.
Yeah, you go on to slideshow.
Yes, ma'am.
In view, you can go into slideshow mode. Yeah.
Yeah. Now it's visible.
But you have to go to slideshow.
Yeah, I can see my slides, ma'am. My slides are visible, ma'am.
Yes, but it's not on slideshow.
Okay, I have shared the slides in slideshow mode only, ma'am.
Then maybe you can keep clicking on different slides and talk.
Is it okay, ma'am? It's coming.
We see the slides.
Yeah, I have shared the slides in slideshow mode, ma'am.
No problem, John. Go ahead. Go ahead.
Okay. Very good evening to all of you. I'll be presenting nuances of pterygium surgery. So I have no financial interest. It's a solely academic session. So plan of presentations are basics of pterygium surgery, different methods, how to approach in pterygium and the cataract, and when trapped, how to come out. And
Sir, Dr. John, can you stop share for a minute?
Yeah.
Now just do when you do the share, you will have a PowerPoint slideshow option. Just click on it. When you do the screen share now, green button, you will have, just do the slide share. On the bottom, can you do the slide share? Yeah.
Is it?
Can you stop share for a minute, sir?
Yeah.
Stop the share, sir.
Yeah.
First, put it on slideshow mode. Yeah, the presentation, put it on slideshow mode. F5.
Yeah.
Come back to the Zoom window. Click on share screen.
Yeah. I'm sharing already.
No, it's not.
It is not coming. You can just, now it is come.
This has come?
Yes, now, good.
Yeah.
3 cheers for Sunilji.
Yes.
Thank you very much. I'm sorry for the inconveniences. I'm again starting. Very good evening to all of you. I'll be presenting nuances of pterygium surgery. So the plan of presentation will be the basics of pterygium surgery, different methods, how to approach in combined procedure, and when trapped, how to come out, and what are the technique messages. So it is why important because it's your tip of iceberg, because the first surgical experience in the for the resident, exposure to the ocular surface surgery for is first surgical learning curve and a good outcome. Lots of things to learn from it. So this is actually I'm sharing one of the basic surgical technique of the pterygium surgery.
Can you change your slides? Go on to the next slide. You're not, probably you are moving on, but we are only seeing the first slide.
Yeah, I'm moving, ma'am. I can see slides are moving, videos are running.
We are still on your name one.
We are still on the name.
Oh, ma'am. Okay, I'm sorry. I just something maybe network issues are there, ma'am. I'm just sharing. I can see. Yeah,
I think you can do like the way ma'am was saying, click one slide at a time.
Go to the, do not be on the slideshow. Keep showing one slide at a time. That's why, we need to always do a
rerun.
Yeah.
Is it now?
Yes.
Change one slide. It's not changing.
It's not
changing.
So do not go to the slideshow. You keep changing one slide as you talk. Mr. Sunil, could you advise him?
Just go back. So just do the escape. Just click on escape.
Yeah.
No.
Stop screen sharing and then again.
Sunil.
सुनील जी आपसे हेल्प मांग रहे हैं.
Sir, just click. Sorry, I was muted while I was speaking. Sorry. Just click on the share screen button and just do the share.
Is it now?
Can you just click on the screen once, and then go left and right or up and down?
Yeah, it's
Yes,
coming.
now it is moving. Perfect.
It's
okay.
coming.
Perfect.
Yes,
Perfect.
yes,
Maybe
Am I-
let's not start seeing perfect. Let's see him go on.
Yeah.
yes.
So I'll move on the slides. So
Yeah.
why it is important? Because first surgical experience for the resident, an exposure to ocular surface surgery, and the first surgical learning curve, and good outcomes are there, because lots of things is like a tip of iceberg. So I'm sharing the first of the basic. My
Yes, yes, yes.
Yeah. Okay. So this is actually I'm showing one of the just how to dissect the things. It is with the cataract surgery or without, the basic surgical technique will remain same. We have to dissect the things. Remove all the tissue, and then followed by the grafting will be there. This is the basic technique for the things. So once it grafted there, it can be, if you don't have the options, if you're resident one, they can use the tangible sutures for this the purpose for secure the things. But probably autologous blood can serve the purpose also. The same thing we can see with autologous blood. This is a huge heptic pterygium was there. The graft was there by the autologous blood, and this is for 6 weeks post-op. You can see absolutely the clear cornea with the graft in situ. So this is another year which is the fibrin glue, which doing our task very easy. We are removing the graft. Place exercise these things and placing the fibrin glue and place it over there. It reduce the time as well as more secure the things. So I'm not going in details of the things. Now these are the complications of the grafts, whether it treated or not. What are the graft compliances? Now I will move to our main talks. When the bilateral pterygium is there, we are using the AMT. This is another video. Once it is removed, we cover the whole ocular surface AMT and secure with fibrin glue, taking the graft from the superior temporal part and make a small niche over there and just place it at the limbus in either of the sides as a border like things, and they will secure them the surface and placing the base. So these are actually basic pterygium surgery. Now, and you can see this is a pre-op, this is a both head and this is a post-op. Now, what happened? When the patient comes with the pterygium, the cataract, so how to approach us, and is single or your stage procedure combined, or what will be the biometry, or it is SICs or FECO? So sequential surgery or it's a combined surgery? When should I sequential? When the pterygium is extensively high, it covering almost encroaching central visual axis, and we are getting the abnormal visibility, or there is a key reading is abnormally coming. So better in those situation, or it's double-headed pterygium, or it combined the cataract. So better to go ahead with the first pterygium surgery, stage surgery. Then when the predictable surface is quiet and the predictable key reading get, then we'll better go ahead with the cataract surgery. Then what will be the biometry if you're combining for the cataract surgery, SICs or FECO with the pterygium? If the pterygium is not involved with the central 4 millimeter, then we can go ahead with that, because we can get the K Meyer. Then we can do the formulation. It's a standard K or your SRK formula, which will be the K reading. If the grossness or the K reading is decided, then we can do by the topographic K or same K. And what will be the post-operative refraction? Definitely, whenever there is a pterygium is there, they usually aggravate with the rule astigmatism. Whenever, so we should predict the things whenever we remove the pterygium. So definitely the pushing part is withdrawn. So usually they push the eye in the myopic shape. That should be considered while planning for the combined surgery. So I'm just sharing one of the patient. This lady having a heptic pterygium with the NS3, and we are doing the topography. This topo is showing this patient almost 7 days after patient having the astigmatism was there. You can see that that steeper curve is approx 44 and the flat curve was 37. And What we planned for the we have done with the biometry. The center as the central K was clear, we can get the only the 44 and 43 the K rating in the CISPER. So we have done simply the clear cornea phaco here, temporal approach, and do the pterygium surgery and taking the graft from the superior part. And you can say post-operatively, though there is a high hyper of patient, the biometry of the patient having the 26 biometric power, and post-operative there is no single astigmatism, and he having the 6/9 vision without any astigmatism. So I'm just sharing of the combined surgery video. So these are actually combined surgery planning for the phaco. Sorry, you can see my videos are visible, ma'am.
Yes, visible.
So after doing the rexis, I noticed that the visibility is not. I'm not taking the inferior temporal part. So what I move on to, I remove the head of the pterygium to increase the visibility. So if you're planning for the surgery for the combined even also SICs also, then if there is visibility is poor, if you combine plan, then we can just remove the corneal part. Then for once the cataract surgery, either of the SIC phaco done, then you can complete the procedure. I'm just showing the successive part of that surgery. So once the cataract part is done, we are doing the subconjunctival precision of the pterygium tissue. This is the subconjunctival excised must. Wipe the things. We are taking the tissue from the superior part and mark for the resident, even also for marking is must, because once it's very thin conjunctival graft, you may revert the thing. So better to stain the thing. If you don't have the marker pen, even you can stain it with the trypan blue, which is used for your antro capsule staining. So place it in the proper orientation. Once hemostasis is achieved, we place it over there. It is so thin. And the remaining part I got, and there is a, so it's well covered by the pterygium. The base is well covered with the and secured fibrin glue. And the host side also secure. So this is one of the slides I'm sharing. This patient came to us immediately. Somewhere it has done the pterygium surgery with the SICs, and he came with us this type of and graft having the subconscious hemorrhage. So this is actually what we have done. They have the remaining part also. Pterygium graft was not properly cleaned off. So whenever we are planning for the combined, so I don't have the personal slides for the combined SICs with the pterygium. What I want to share by the slides, if we are planning for the pterygium surgery with SICs, so better hemostasis should be there. Sometimes what happens whenever we are doing the pulse surgery SICs, we don't cauterize the muscular tunnel or conduct subconjunctival bed. So better in those cases, selective cauterization of the conjunctival bed for nice tunnel. And whenever we are planning for the taking the graft, as already we are cutting the superior conjunctiva, so we can harvest the conjunctival graft from the inferior temporal part and place it properly. And while we are actually this patient already graft was there, we didn't remove this graft. Simply I've taken the patient and I dissect the thing and the remaining part of the residual which was left behind. And this is after the 2 weeks of the 3 weeks of the first presentation to us. And whatever the phaco and SICs, definitely either of the one can be done. But if SICs also with the resident doctor when they are planning for the cataract surgery, if it is encroaching central part visibility is poor, in those cases better to go ahead first. Your pterygium, and once the surface will be stable, the care will be proper and visibility is good, and then you can plan for the stage SICs. If the pterygium part is very nominal, in the combined SICs and pterygium can be planned. These are some of the complication. The recurrence, which is the most common of these things. And this is one of the things I want to share. This thing sometimes some of the person using for the recurrent pterygium, the mitomycin has been used. So these are the patients. Whenever you are planning for the pterygium boost and combined with the cataract surgery, you have, if you are using the mitomycin to prevent the recurrence, it should be used proper and judiciously, because your inadvertent exposure time that causes the melting of the sclera. This patient came to us with after 1 month of the cataract surgery, and their superior wound was so bad, and because tunnel was done from superiorly and from the temporal part, that's why melt was there. So whatever this, you can see this melt was there. We have done the debridement of the tissue, and then the scleral patch up done, and followed by CH. And these are the 6 weeks after the. This is the ocular surface reconstruction, and you can see these are the primary pterygium site, and this is the superior part where the graft was taken. So these are the from some of the complications. Infection can be there, and these are scarring. And if there is residual after the cataract surgery, if there is a residual, astigmatism is there, it can be you can wait for some time to stabilize the refraction. Don't jump for the any surgical procedure first. Even if residual scarring is there that causes the your cylinder part, then we can trial, give the RGP trial, or we can give the plan for the if it is persistent and patient is very much keen for the visual rehabilitation, then in this case a PTK can be tried. So technical messages are: pterygium surgery management should be in molecular and cellular level. Sequential or combined cataract surgery should be planned according to the case with a maximum outcome, which I have learned from the previous speaker too. Also, whatever we are doing, we have to give them rational. Ultimately, that patient should be happy the next morning, and I should be quiet. Early detection of the complications and the prompt action against it must, and never hesitate to refer your patient whenever you think that the things are not amenable by yourself. Thank you very much. Thanks for your patience. And these are some of the relevant studies AIOS, and which is really good. Well, thank you very much.
Thank you very much, Dr. John. Now we shall go on. Could you stop sharing your screen?
Yes.
Dr. Deepak, are you there? Dr.
Yes,
Deepak?
I'm there.
Yeah. Now, if it is a old patient, glaucoma suspect, and a kind of cataract which makes you think it's better to do an SICS surgery, where would you locate an incision and where would you get the graft from?
Well, that's a very tricky situation. See, if you're planning for to spare for future trabeculectomy, I think that this is much that higher rating. So we need to more cataract incisions elsewhere. So I would definitely do a temporal incision with an inferior graft. So
Yeah.
most for my pterygium surgeries, I always use the inferior graft. That's not a big issue. For SICs, again, I'll go and do a temporal SICs with an inferior graft. For most pterygium surgeries, I always use an inferior graft.
Yes.
And as far as the combined surgery, sequential surgery are concerned, when you are a cataract and a phaco surgeon and you're using SICs and a phaco surgeon, and SICS is a bailout situation in very advanced dense cataract, leathery cataracts, or a pupil, small pupil, and all those kind of situations, and a very old patient. Would you still be firm about removing the pterygium, waiting for the case to stabilize, and then do a cataract surgery? Or because now all of us are very conscious of doing every surgery as a premium surgery. Would you wait or would you do it both at one sitting? And what's your reasoning for that?
It purely depends upon the need of the patient at that particular scenario. If the patient is desperate for vision, then we have to sacrifice perfection there. So I would not hesitate to do just only cataract surgery or do a combined cataract and pterygium surgery. Although the refractive outcomes will be less than optimal, but depending on the need of the situation, the patient requires an urgent visual rehabilitation. She's elderly, he or she is elderly, and the cataract is very dense. And these are situations where I would deal with the cataract first or deal with the cataract along with the pterygium at the same setting. Otherwise, if the visual needs are not so desperate, my usual go-to strategy is always deal with the pterygium first, allow the cornea to stabilize, the astigmatism stabilize, then plan for cataract surgery accordingly.
Yes, yes, exactly. Those were my thoughts. I just wanted to hear it from you. Dr. Ravindra, I wanted to ask you, for a learning surgeon who's going to be suturing the graft and doesn't want to use a coffee glue, so what would be the tips you would give for suturing pterygium graft, and when should sutures be removed?
Suturing is not something which is really bad, and it's a good alternative for the glue. I think, Dr. Kamaljit, if you can mute your audio, whenever you muted, we were not hearing the noise. Okay, no, fine. Thanks for that question. It's a wonderful analysis of his cases. Suturing is not a bad idea at all. We have been using sutures for such a long time. Suddenly, because of the glue availability of glue, it has become bad. So when you suture it in such a way that the knot goes inside. You start from the inside the conjunctiva and go out, and knot goes inside. So post-operatively, you're going to be very comfortable. There won't be any discharge and irritation and all those things to the patient. Many times post-operatively, they fall off. 2-3 weeks later, you'll see that they're gone. And otherwise, you can always snip it with a needle and pull it out with a forceps post-operatively. Probably about 10 days to 15 days is a good time to remove the sutures if you have applied them.
Yes. Yes, very true. Shall we go on to our next speaker? I think.
Yeah. You can use blood also. Sorry.
Yes, Dr. Boramani. Yes.
You can use autologous blood also. That works very well as a glue.
Yes, yes.
Yeah, I agree with you, sir. Most of the surgery, whatever you are doing, ocular surgery, even if it is extensively ocular surgery reconstruction, that time we are preferring the glue if it clamped up with AMT or slits. Otherwise, if it is simple pterygium, autologous glue, it does nicely work.
Yes. Yes.
The suture that I would recommend is 10-0 monofilament nylon, which gives the least amount of irritation, and cut it right on the knot. So that doesn't give any inflammation or a stimulus for the growth of blood vessels or recurrence of pterygium.
Yes. Absolutely. All very solid points. So we shall now go on to our next speaker, Dr. Sharmila, who's a senior medical consultant at Arvind Eye Care Systems, Madurai, and one of the senior consultants in the glaucoma services. And she is going to tell us something different, a combined surgery again, but a combined SICs trap, the tips and tricks. On to you, Dr. Sharmila. May have to unmute yourself too. Today we seem to be having too many glitches.
Yeah, I'm sorry about that, madam.
Not yours, generally, I mean, today it was.
So thank you very much, madam, for that kind introduction. And I hope my slides are visible and I'm audible also. Just
yes.
Thank you so much. Yeah, so I'm going to be talking about combined SICs trap, the tips and tricks involved in this. So this is a beautiful picture of nature at its best. You can see the coast, the beach, the sand, the waves, the sea. It's definitely beautiful. It's not my vacation picture, as probably would be expected by Dr. Chitra. This is a zoom picture of pseudoexfoliation syndrome. So why I put up this picture? We all know that cataract and glaucoma often coexist, and phacoemulsification with a combined trabeculectomy is primarily the best option in these eyes. However, we may not be able to do phacoemulsification in all situations. So choosing the right technique is the first tip I would like to give, depending upon the patient, depending upon the need for that particular patient. So that is a tip number one. So tip number 2 is an adequate preoperative planning. I always believe in doing a good planning before anything, whether it is surgery or whether it is in any other situation. I always love to do a good preoperative planning. So I do a careful slit lamp examination. I assess, most importantly, the size of the pupil, the grade of the nucleus, the zonular integrity, presence of pseudoexfoliation, the status of the angle, any peripheral anterior syndicate that is present. All this will give me a clue as to what kind of surgery I'm going to be doing for that particular patient. So the choice of surgery is very, very important. And even when I'm going to do a technique, the SICS strap, there are different techniques of doing an SICS strap. So I will probably choose which is the technique that I'm going to undertake for that particular patient, and using antimetabolites, what is the mode of delivery of the antimetabolites, the type of sutures I'm going to use for those patients. So all this preoperative planning is really very crucial for a good surgical outcome. And tip number 3, we all know that Peng Tiko is a big man in glaucoma surgery, and he has framed the 5 mantras for a good surgical success in trabeculectomy. So basically, the first one is treat a larger area with antimetabolites. Second thing is you direct the flow posteriorly. The third thing is you always make a larger scleral flap and do not cut it to the limbus, and make a single scleral punch sclerostomy. And you also choose to do more of releasable or adjustable sutures than the fixed sutures. So now moving on to the real surgery. So there are a lot of intraoperative tips as well, which will be very useful to have a good successful outcome, even if it is going to be a larger incision surgery like SICS strap. So the first thing which I have not included here is the conjunctival dissection. We all know that conjunctival dissection is a very important step, and we have to carefully handle the tissue with meticulous handling of the tissues with good instruments, and do not cause any undue tears in the conjunctiva, because that might lead to any kind of leaks postoperatively. Tip number 2, which is actually the use of mitomycin C injection. So there's always a debate as to how to use mitomycin, whether to use sponges or whether to use an injection, and how much to use and all that. So recently we have moved towards using injection mitomycin over the sponges. The reason for this is it is takes lesser time. There's no dealing with sponges. And we also know that the exact concentration is delivered to the eye. And this can be spread evenly in a larger area. So I'll just show you the video. So mitomycin C injection, what you use is typically the same concentration as what you use it for the sponges, but you take only 0.5 ml of that and then mix it with 1.5 ml of lignocaine. So I prefer to, I'm sorry, this video is good. So I prefer to use it 8 to 10 millimeter posterior to the limbus, like what you see here. And then I spread it out evenly and then start the conjunctival dissection after a couple of minutes. So this is the conventional way of using mitomycin, where you count the number of sponges. The first sponge to go inside should be the first one to come out also. A lot of care has to be taken because you have to count the number of sponges. You have to do a thorough irrigation after removal of the sponges, and make sure that you don't touch the tip or edges of the conjunctiva when you're using mitomycin C. So the second tip is wound construction. We all know for any building, the main structure that has to be really taken care of is the foundation. So likewise, even for any surgery, the success of the surgery, like what we heard from Dr. Tamilarasi, beautiful videos she had shared. So it is all depending upon the wound construction. A good wound construction actually saves half your surgery, and as well as it also improves the success. So I would always love to concentrate on the scleral flap. It should be a uniform thickness scleral flap. It should be a larger size or a smaller size, depending upon the length or the density of the cataract. And it also depends on multiple factors. Like, one is the skill of the surgeon, how skillful he is in doing that particular procedure, and depends upon patient factors like pupil dilatation, nuclear density, etc. So there are different kind of wound construction. Like triangular flap itself, you can do it like a wide triangular flap incision, or you can do a W-shaped incision with a side SICS kind of an incision, or you can take a rectangular flap, or just do a SICS tunnel-shaped tunnel which you use, and then use that as a flap for making the sclerostomy. The second, these are the videos which I would like to share. So this is what is a small triangular flap with a side incision, what I mentioned. Make sure that you take a uniform thickness of the scleral flap. And when you're going towards the side, you have to be very careful, because you should not have any undue cuts there. And then you just bring it out just like how you're doing an SICS tunnel. So this is one way of doing it. And the other way of doing is make a larger broad-based triangular scleral flap. So this is usually preferred for a slightly more denser cataract. So here you see a larger V incision. And then similarly, you dissect it out with uniform thickness, making sure that you do not cause any kind of buttonhole or differences in the level of dissection. You should have a uniform thickness. Make sure that you take adequate care to maintain this uniformity throughout. When you reach the base of the flap, that is very important. You have to make sure that you angle it a little superficially so that you can see the blade there, and make side pockets and then do it. The other one is a routine SICs surgery, what we do. So this is a straight incision, and then you finish the surgery, and then the difference will be shown a little later. So the most important step is the internal ostium. Again, the internal ostium also, how much of internal ostium has to be cut and where it has to be done is all, again, important tips. For example, the first incision, what I told, a small triangular incision, you just make a single punch with sclerostomy using a Kelly's punch. Make sure that you meet it till the surgical limbus, that is the blue and the white sclera meets. So this is adequate for this particular type of incision. Whereas if you take a larger, wider, this is in the SICs flap, a straight incision, where you take the midpoint of the incision and then under the scleral flap, make a sclerostomy. And in the case of a larger triangular scleral flap, you can do 2 with distance or 2 with distance of the punching. And similarly, you extend it until you reach the surgical limbus. So why this is important is because in the wider flap, you have a wider coverage. So there won't be any chance of hypotonia or overfiltration in these kind of flaps. But whenever you have a smaller triangular scleral flap with the side incisions, it is better to make only a single scleral punch. In case you're making a wider scleral punch, it will be leading to more of hypotonia or overfiltration. So that is the reason why we are doing this. And then the peripheral iridectomy, we all have to make sure that we have a good size peripheral iridectomy. It should be a little larger than the inner sclerostomy opening. I also prefer to use pilomin in some cases where you do not really know how much of iris you're cutting out. So once the pupil is fully dilated in these cases, because we are doing a combined surgery, it's difficult to identify how much of iris you're cutting out because everything will be bunched there. So you can use a pilomin at that particular point of time. So here you can see that in a straight incision. So you lift up the scleral flap and then just pull out the iris and then do a incision there, excision of the iris there. And here you can see that you make sure that it is precise and wash out the tissue very clearly so that there is no iris tissue which is blocking the ostium. So the tip number 5 is good scleral flap closure. So there are different ways of closing the scleral flap, and number of sutures also might be different according to the flap size or what kind of flap you have taken. So generally I prefer to use, in a case of a small incision triangular scleral flap, I put a single fixed suture at the apex. Apical suture is really very, very important. That has to be really tight and it has to be firm. Always ensure that your eye is firm when you're doing any kind of suturing, because you're doing it under saline and you need to have to, assess the integrity of the wound. And this is a releasable suture where we usually use a 10-0 nylon, reverse the needle, take it out to the cornea, bring it out through the cornea, and then from the sclera and again to the base of the scleral flap, 4 throws, and then you tighten it. So the advantage of this is there is a small loop here. So it will not cause any irritation by a free floating end there. And this can be pulled out. In case you don't have an access to a laser machine for doing a suturolysis, this is very, very helpful. And one other thing what I would like to show is in an SICs straight incision tunnel, you can use just 2 sutures on either side of the sclerostomy like what is shown here. I always prefer to bury the sutures because we also heard from Dr. Ravindra, it's very important to flush it, cut it very close to the suture and bury it under the sclera. And the last step is the good conjunctival closure. We all know that we have to ensure that there is a watertight wound closure. So again, there are different ways of doing it. I generally take a good anchoring suture with the sclera. So conjunctiva, sclera, and then conjunctiva again, and make like a mattress suture here. And you can also do the same thing on either side, or you can pull the whole conjunctiva to one side and you can suture it. The idea is basically to have a watertight closure. Sometimes you might see a small frill of conjunctiva, which is very loose at the apex. In such cases, I usually use an anchoring suture where I take a bite from the cornea to cornea, bring it out to the conjunctiva, reverse the needle from the conjunctiva, and then take it out and tie it to the sclera, to the cornea. So there have been a few studies which have compared SICs trap with phaco trap, and this is a very popular study by Dr. Ravi Thomas, where he has compared both, and he has found that there is no clear difference between the two in terms of IOP control, visual acuity gain, or any induced astigmatism. And this is the most recent article which I came across, which was published recently in IJO. They have compared only in pseudoexfoliation eyes the SICs trap versus phaco trap. And again, they found that SICs is not inferior to phaco trap in terms of surgical outcome. However, they found that the zonular dialysis is more in pseudoexfoliation glaucoma in phaco compared to that of the SICs. So the take-home message here is combined SICs trap is a safe and effective alternative to phaco trap in special situations like complicated cataract, poor dilating pupils, zonular dialysis, heart cataracts, etc. SICs trap, though safe and effective in terms of IOP control, it does not improve the long-term web survival because it induces a lot of inflammation intraoperatively and postoperatively as well. Choosing the right technique, therefore, should be based both on patient factors as well as the skill of the surgeon. I would like to conclude by this quote: good surgeons know how to operate, better surgeons know when to operate, and the best surgeons know when not to operate. I always like to be the best of the surgeon, and I decide when not to operate. Thank you so much for patient hearing.
Thank you so much, Sharmila. As usual, nothing but the best could be expected from you, the crispness, clarity, and the kind of videos. But the last take-home message of yours sort of answered one question which I had, because personally, I have done more phaco traps, and I know you are a person who would have done enough of phaco traps and SICs traps too. So though that message tells a final answer, do you also believe that compared to the two, SICs trap versus phaco trap, the final outcome, IOP control or the long-term bleb success is definitely more query in SICs trap?
This is kind of little difficult to answer because head-on comparison have shown almost the similar kind of outcomes, although we have better benefits with phaco trap in terms of, early rehabilitation, and they just, the recovery is also faster. But in any kind of trabeculectomy, the outcome depends upon a lot of factors. I think it depends upon, how many medicines they are using preoperatively. That also has an influence on conjunctival cytology. It also depends upon everybody's individual healing response, because the body's healing response for A is not the same as B. So a lot of factors come into play there. So, but however, whatever said and done, this has a larger incision. And in SICs trap, what I thought was we are doing same site procedure for both, whereas in phaco trap, we usually separate the wounds. So I tend to do a temporal phacoemulsification and then do a superior trap. So that also might be a little more advantageous. But scientifically, there's nothing proven as such.
Okay, as far as the management is concerned, I would want you to outline how you would do the post-op management in the phaco trap versus SICs trap.
Okay. Pretty much it's the same, because we usually follow that 6 times a day for 2 weeks, and then we taper it like every 2 weeks until we reach for once a day. So it goes up for I think around 2 months, and then in SICs trap we add a cycloplegic. It again depends upon how much of iris manipulation and all that is there, and then generally we stop all anti-glaucoma medications. Of course, we would check the intraocular pressure. However, if there was a preoperative there is a severe glaucoma, then I tend to keep them on at least 1 drop to have kind of like a safe thing to avoid any undue pressure rise post-operatively, causing compromise on the optic nerve function. Yeah.
Now, you presented a case series randomized control study where you have compared a phaco trab versus a SICs trab, where in those small eyes where you did a prophylactic sclerostomy too. What were your comparative results?
The comparative results of that is in non-ophthalmic eyes, just to give others the idea about this. This was in short eyes. We have compared 60 eyes of patients undergoing cataract procedure with a sclerostomy and without sclerostomy. Number one, sclerostomy definitely helped in reducing complications, more significantly with uveal effusions. However, in both the groups, there were patients undergoing both the procedures, that is phaco with sclerostomy and SICs with sclerostomy. Similarly, phaco without sclerostomy and SICs without sclerostomy. So in both the groups, either of the groups, the SICs had more complications than phaco. The rationale here is we need to have a smaller closed chamber, because there is kind of like undue pressure that can develop during surgery. And this pressure differential is the main reason for most of the complications. So it's also preferred to use AC maintainers. Make sure that you always maintain the chamber. So that is the key here. So in an SICs, it is, although it is a tunnel wound and all that, we have a larger incision, and these eyes are more prone for positive pressures intraoperatively. So that can itself cause a lot of intraoperative surprises.
Dr. Ravindra, I'm sure you would have an answer different from this too, from your experience. So let's hear from you.
Yeah, I think glaucoma fascinates everyone. So that's the most challenging scenario, and surgical scenario is definitely an option for cases where you cannot manage with the medicines. Number one, I have a lot of questions, Dr. Shamila. Wonderful presentation. I learned a lot from your talk. One is, you said when you are applying sponges, you diluted 5 ml in 2 milligrams, while we use 10 ml in 2 milligrams. And also when you're giving injection, you said you dilute 0.5 in 1.5 ml of this solution. That comes to, what is the percentage, around 0.01 or something?
0.1 milligrams, sir. It'll come 0.1.
0.1 milligrams.
Yeah.
So, okay, then how do you react to people who are using little stronger mitomycin for sponges and little more diluted mitomycin for your I mean, this comes to what we use. I inject the same dilution, 10 ml in 2 milligrams, 0.1 ml of it, less than 0.1 ml, 10 mm away from the limbus. So how do you react to the results between the two?
We actually, one of my
different solutions, yeah.
Yeah, actually, the thing is, sir, when we are using sponges, the concentration of mitomycin is slightly more. The reason, yeah, it's more actually. It's more than what we use for the injection. The reason why the concentration for injection is lesser is we really do not know where it is exactly diffusing. So that is one thing. With sponges, you just wash away. Here, we're not washing away.
What is the comparative? You might not have published, but you know, off the cuff experience between the two.
So we have published that. It has come out in IJO, and the mitomycin C injections are equally, I mean, it is equally effective as that of the sponges. However, only the fibrosis, but the fibrosis was slightly more with the sponges. That's what we saw. And our short-term follow-up was only for 6 months. But regularly we've been using this. One, because actually a lot of situations we have faced earlier where there are some kind of like retained sponges or scleral melt or conjunctival melt, we have seen that again, it is not typically because of the use of sponges. It is because of some negligence intraoperatively, possibly because there was a retained sponge where we did not remove it adequately. But using this injection was kind of like, it was more faster for us, and it was better. We did not find much of a difference when we used it along with the sponges, when we compared a head-on comparison. So that's the reason we have shifted.
Is there any difference in the appearance of the blood post-operatively between the two techniques?
No, sir, not really.
The next is, you showed us a couple of ways of making these scleral flaps. One of them is without scleral flap, like a standard SICs, and making a trabeculectomy there. Is there any difference in the post-op appearance or the results between the 2 or 3 techniques that you demonstrated?
Actually, this kind of technique, what we, the straight incision, we have just kept it like the last reserve, and it's usually for brown cataracts because it's very difficult to, do it in the triangular scleral flap where you might be having difficulty while you deliver the nucleus. So personally, I have looked into those kind of blebs, and I somehow felt that the bleb was not so good in those eyes. So I usually reserve it only for, the real hard cataracts where you cannot, it's not amenable to phacoemulsification, and I want to have kind of a safe surgery. Or now more recently, I have even stopped doing that, and I probably limit only to doing a cataract surgery and then put them on medications or go for any other alternative. Like in case if they need a good IOP control, I might go for a micropulse laser, which has come out recently. So that's what I would do. Now I've actually, frankly speaking, I've cut down on doing that straight incision combined.
Okay, the last question from me is that as we have shifted to temporals, it's very difficult to do a combined procedure. That's the reason why I shifted about 2-3 years ago to dual site. I do it superiorly the trabeculectomy and temporally the cataract surgery. My analysis of hundreds of cases show that the dual site technique, that's what Dr. Chitra was telling, dual site technique is mandatory in phaco surgery. But then that's given slightly better results when compared to the single site I was doing superiorly or superior temporally in earlier case. How do you respond to this?
I too feel the same. So the minute you separate the incisions, it is a lot better because I don't know, the kind of like the fibro, there's so much of conjunctiva that you dissect there, and then which induces a lot of fibrotic response. So all that is there. So separating the incision, definitely it is having an added advantage in helping in the success of the trabeculectomies.
Lovely questions, but I think we have to do justice to 3 more speakers.
Okay,
so sorry. I mean, it's been a wonderful learning, very nice presentation, Dr. Sharmila.
Thank you.
We will now go on to Dr. Satanshu Mathur, who's the medical director of High Tech Institute and Laser Center at Kashipur, and a very popular, very in the national stage, and he's an extremely friendly and a very versatile, prolific surgeon. And let us hear from him. He's taken on a tough topic: black cataract and low endothelial cell count, my approach. On to you, Dr. Satanshu. I think I saw Dr. Satanshu.
Dr. Mathur, you need to unmute yourself first.
Thank you, Dr. Chitra.
And I should also add a very hardworking surgeon who's showing us presentation between surgeries.
So, Dr. Chitra, actually, I am having problem with the nerve here. So, if somebody else is there before me.
Sir, you have 2 devices logged in. Please log out from mine.
Dr. Chitra, I am having problem with the internet. So, if somebody is, I am having problem in net. If somebody else is before me, he can speak.
Yes, we shall now, but do let us know, Dr. Satanshu, don't disappear to the next surgery. We shall now go on to Dr. Navneet Kumar, who's a senior medical consultant of intraocular lens and cataract services from Ashwin Eye Care Systems based at Coimbatore. And he is going to take us on to another challenging terrain: micro-cornea and coloboma, how to deal with a hard nucleus. On to you, Dr. Navneet.
Is it visible now?
Yes, yes. Okay.
Is it visible now?
Yes, but
yes, we can see.
No, we are seeing Dr. Navneet's opening.
Dr. Chitra, is it visible now?
Mr. Dr. Navneet, maybe you could stop sharing for a minute. Dr. Satanshu is also trying to share. Yes, Dr. Satanshu, can you share?
Dr. Satanshu, you need to screen share.
Dr. Chitra, is it visible now?
No, you have to share your screen. Press the
we can see you, but not your presentation.
Continue with the other speaker.
Dr. Satyajit, Dr. Satanshu को थोड़ा साइड में बता.
हम फोन करके बात कर लेते.
ठीक है. Dr. Navneet, you could reshare your screen. Sorry.
Yes, ma'am.
Thank you for the opportunity. Is my slides are visible, ma'am?
Yes.
Thank you for the opportunity. I'm Dr. Navneet, medical officer from Arvind Hospital, Coimbatore. Surgically relevant associations of coloboma are small eyes, micro-cornea, shallow anterior chamber, small pupil, inferiorly deficient iris and zonules. Associated retinochoroidal coloboma, which decides main visual prognosis. This is a case of hard black cataract with micro-cornea and coloboma. ECC incision is given, which is of 8 millimeters length. Better is a valvular incision instead of a stab incision. This followed by a side port, mainly sclerocorneal, as if only corneal, it may obscure your view of during surgery. Here, people got dilated with sufficiently with intracameral midriatic, capsule stained with capsule stained and keratometry made. We can notice with the cystitome, we can notice a grossly bag, making the rexis difficult. So capsular forceps used to make the rexis as big as possible. Nuclear dialing attempted bimanually with dialer.
Dr. Satanshu, please mute yourself.
Okay. So as it was difficult, relaxing cuts given over the iris as a superior iridectomy, and this followed by rexis relaxing cuts given with venous, and delivery reattempted, one pole dialed out followed by a vectis delivery, which got stuck at the tunnel. Now the tunnel relaxing cuts given and delivery reattempted. Nucleus delivery became successful with superior iridectomy, rexis relaxing cuts and tunnel relaxing cuts. This followed by gentle visible cortex wash. Now the challenge comes as we have to implant 13 millimeters lengthy IOL with 40 diopters power in 4 millimeters cornea. So haptics were trimmed so that optic size becomes 6 millimeters, and we are able to implant in the bag. This followed by visco wash and ECCE wound suturing. Here the trick was, first I took all limbal to sclera bites all at a time and tied all knots at once, so that I can assess the tightness of the knots in more synchronized way. This is another case where the challenge was small pupil. This can be dealt with iris hooks, which were needed mainly in the superior quadrant. Extra side port made above the tunnel to put the third iris hook, so that I can view the superior part enough to visualize the rexis. After doing enough large rexis, Iris hooks were removed to facilitate the remaining steps in the surgery. Nucleus dialed into anterior chamber and delivered with vectis. Here jonules were intact, so IOL kept inside the bag. This is another case where the challenge was inferiorly weak jonules. After sufficiently large rhexis, mild hydrodissection is done, and weak jonules are supported with CTR. And the rest of the surgery is continued in a similar way. This is another case where the jonules were deficient in the inferior part. So after completing the rhexis with capsular forceps, CTR placed in the deficient area. CTR got slipped from the bag because of the extended rhexis. So at the end of the surgery, CTR explanted out. And 3-piece IOL implanted in the bag, and its haptic fixed to iris with the help of a Prolene suture passed below the haptic through and through the iris, which corrects both colobomatous iris defect and fixates the haptic of the IOL with one knot. This is the same 4-throw pupilloplasty which fixates both IOL and the iris defect. In summary, ECC is the choice of incision in micro-cornea and small eyes. Iris hooks and superior iridectomy can counteract the small pupil. Jonular weakness can be supported by a CTR. In gross jonular deficiency, iris fixated IOL or a scleral fixated IOL may be needed. In case of RC coloboma, which involve disc and macula, better to go for a basic IOL packages. Thank you.
Thank you, Dr. Navneet. That was truly a wonderful presentation, and lot of examples and take-home points came. Thank you very much. I would take the question with anybody in the expert panel, Dr. Ravindra and also Dr. Deepak Meghur. Anybody could answer. We all know that there is a disproportion in small eyes about the anterior chamber being shallow, very shallow in these micro-cornea eyes, and also the nucleus could be very large too. So what is the approach to prolapse the nucleus in these cases? What tip would you like to give? Even Dr. Navneet, you could answer. Anybody?
Same thing, ma'am. Larger incision with a, and sometimes
ECC. You said ECC. You wouldn't do a SICs, right?
Yeah, ECC is the choice of incision in my case.
Yeah, Dr. Ravindra, Dr. Deepak Meghur, anybody, Dr. Boramani, anything different you have to comment on this particular situation?
No, about the wonderful videos. I think they're all very heroic surgeries. I think I should really compliment
Yes.
Dr. Navneet.
Yeah.
The one thing is he cut the haptics and put the lens inside the capsular bag in one microcornea. And how did he manage? Was it a PMMA? It looked like a PMMA lens, if I'm right, isn't it?
Yes, sir. It's a PMMA.
How did you manage to put a 6mm PMMA through probably a 3 or 4mm axis? What was that? And what about the rough edges of the cut portion? Does it damage the capsular bag? And how did the patient do
Iritis or inflammation?
Post-operatively, how did the patient do?
We saw the 6 months post-op also, sir. It was looking very stable also, sir. Like,
which is a situation when we would not implant an IOL in a microcornea. It's a hypothetical question, but I'm sure such a moment might come when there's a certain corneal diameter, I believe, no? But when smaller than that, we would not implant an IOL, right?
Yes.
Many times it depends upon the axial length of the eye. If axial length sometimes is normal and you have only the microcornea, and I will expect the lens to be of a larger size. I think it's nice to have a different collection of lenses with you. And many times you will be able to, like a 9mm, 8mm cornea has got 23mm axial length. Probably the lens size is normal, and you can find out by, UBM preoperatively as to the size of it, and then plan the exact size. And any lens can be custom designed. And we're fortunately in India, and we can make lenses. I've made lenses of 10mm overall length. I've made lenses of 8mm overall length. And they're very happy to make and give it to you, though they're a little expensive and takes time. Custom designed lenses are a way to go in these eyes.
He showed iris hooks being used in small pupil. Now, since this is a lens coloboma and an iris coloboma, the rexus, it's going to be a little decentered. Does it not make sense that even in routine cases, wherein we could end up with an asymmetric rexus, that we use iris hooks in all cases? Anybody think similar? Or would you reserve using iris hooks only for small?
There are two things that I would like to say. One is that in these eyes, usually the cataract is very hard and cornea is little smaller. So one has to make a very large incision in these cases. And as Dr. Navneet has shown, extracapsular is the right way to go. And pupil dilates in most of the cases. Some of the cases, as G so they may not dilate, then you can use iris hooks. And the nucleus is so big that I would like to do an envelope technique, or even can opener is very good in these cases, because the prolapse of the nucleus becomes very easy if you are doing in a very hard cataract. It might otherwise come with a bag in the anterior chamber. So for the beginners, it's always advisable to do a small can opener technique from the very beginning. Nucleus is hard, you might touch the endothelium and you will have a very bad cornea the next day.
Thank you. Dr. Satanshu, are you ready?
Yeah, I can try now.
Yes.
Thank you, Dr. Chitra. Can you see screen?
No, we see you.
No, we can't see your screen.
See your handsome face.
You press on that green button. You have asked him to open his presentation.
Can you see screen now?
Yes, screen sharing. Excellent. Wonderful.
So, Dr. Chitra and Dr. Satyajit, thanks a lot for ARC. AIOS. My topic is given as my MSIC is in hard cataract. I am fond of doing SICs surgeries, and Dr. Kamalji, Dr. Amindra, all are here, master of SICs surgeries. SICs surgery is especially important in hard cataract. Why? Everybody do not have the advanced machines. Everybody do not have the masterized the surgery of the phaco. So SICs is safe in hands of the surgeon who is not very competent, even in case of not very advanced machines. You can give many type of incision, smile incision, straight incision, front. It depends upon your choice. But for the newcomers, the straight incision and the big incision is very important in hard cataract. Second important thing after incision is the rexis. Recommended Capsulorhexis is 6 mm. In 90% cases, it is successful. So I am giving the straight incision almost. It is big incision in hard cataract, especially for the younger surgeon. And you should make a tunnel not less than 6 mm. It can be 6.5 mm, but not less than 6 mm in hard cataract. Hard means it is black-brown cataract. So once you have completed the incision, you have to check the incision is perfect. If you can make a side port. And staining is very important in hard cataract because we do not want rexis to be extended. So after staining the capsule, Capsulorhexis done, it should be not less than 6 mm in hard cataract. It should be complete CCC, is a better and safe. In hard cataract, you sometimes feel difficulty because of the shallow chamber. So you keep injecting viscoelastic regularly from the side port. Now incision is extended 6 mm outside, and in the side pocket have been made. So inside incision is almost 7 mm. outside is 6 millimeter. Now, copious amount of fluid is injected on behind the rhexis on one side, then on the other side. That will push the nucleus out on one side. So nucleus has come out on the one side. Now again inject viscoelastic and rotate the nucleus by 2 dialer to bring it outside the bag into the anterior chamber. Once the nucleus is anterior chamber, you can take it out by many means, by vectis, by fish hook. In this case, we are taking it out by irrigating vectis. Irrigating vectis, when it goes inside, irrigation is off. When it comes into wound area, irrigation starts. You can say this is black cataract, very hard cataract. So even when the cornea is compromised, by this technique, you can have a better cornea next day in comparison to the phaco. You can implant the PMM lens, you can implant the foldable lens. This is the camp surgery. So we are implanting the non-foldable lens. You will have a better cornea next day, even in compromised corneas where the endothelium is not very healthy. So you can see even 6 millimeter incision is self-healing. We do not have to put any stitch in it. This is another case where we have straight incision and we have extended it vertically up. This is only 5 millimeter incision, but it is extended vertically, you can see. So it has become 6 millimeter outside, but it will produce less astigmatism. Its extension is in vertical direction. In this, you can see, this is special cannula. You can see this is a curve. On this curve, nucleus rests and it comes out easily. And we keep injecting viscoelastic through this cannula. It is 18 gauge cannula. It has a curved structure. On the curvature of this cannula rests the nucleus and it comes out. You can see the hard cataract, it has come out. This is the hardest cataract you can see. So we can implant a foldable lens in this and we can achieve the good success rate. So thank you very much, Dr. Chitra.
Yeah. Wonderful videos, Dr. Satanshu. You showed very well and gave us all the relevant tips of dealing with it. And you have not thought of doing a nucleus fracture, but remove the nucleus end to in all these kinds of cataracts and by enlarging the internal lip of the incision. One question, in case of a situation of a persistent corneal edema, which could be seen in some case, not in, then what would you look for in these cases? Doctor, anybody on the expert panel? Dr. Meghur? Dr. Ravindra?
Yeah, decimus detachment is one thing that you'll have to see many times because of edema, you may not notice it. But you can do an OCT and find it out in that meridian.
Yeah. Anything else, Dr. Sarkar?
Yes, ma'am. Most of the time, actually, what happens this type of cataract, sometimes patient, the primary surgeon thought the edema will goes by hypocell 5 or hypocell 6. If you have doubt or something, better to whatever sir addressed, do a simple AIOS OCT. And in the early stage, if you detect any, if there is a DMD is there, and simply air injection or C3 of it, simply make a hairline scar and make your job very easy. Patient will be happy. And if it is persistent going on, and ultimately, if the fish mouthing is there and there is persistent macular, there is a corneal edema will be there, then you landed up with the PBK. So if you have a doubt for, then rule out the DMD, and if it is addressed properly, then we can just avoid the further PBK-like complications.
Thank you very much. We shall now go on to our last very dynamic speaker, Dr. M.S. Ravindra, and he is going to be telling us, giving a special lecture on nuances in planning a premium IOL in MSICS. We look forward to a very interesting talk from you, Dr. Ravindra.
Do you see it now?
Yes.
Fine. I just asked my staff to give me the analysis of last 1,000 MSICS done in our hospital. And I myself was surprised to see the results. Of that, 32% of all the surgeries, including charity surgeries that we do or low-cost surgeries that we do, 32% are multifocal lens, and 68 are
Dr.
monofocal.
Ravindran, you are not audible properly.
Okay.
No, he's audible.
He's audible, but
He's
put it in slideshow mode.
Yeah.
Okay. He's not audible also, not very nicely.
So we can hear him clearly.
No, this is all I can do. I don't know how
No,
to
no,
put
you
it back.
just go to slideshow, or you keep clicking on each side if you can do that.
How about now? Is that better when I click the slides?
No, the next slide is not coming up. It is just on the first slide. You stop sharing and share again.
How about now?
Yes, yes. Now, can you just try the next slide for us to know that?
Now, did it
Fine,
change?
fine.
Fine.
Okay, now 32% are multifocals of all the surgeries. And if you look at the monofocal lenses, we have 1:2 ratio of imported and Indian lenses. We like Indian lenses a lot, but some people insist on imported. When you look at the Indian versus multifocal of the multifocals, we have a strong priority for Indian multifocals, that 90% of our 90% are Indian lenses, while only 10% are imported. This is what I would like to drive, that the quality of Indian multifocals are extremely good these days, and many times they're better than imported lenses. This point I would like to drive very strongly. And that's the difference between multifocals, imported, monofocal, all of them. But I'll come to the status. Last Indian multifocals versus imported monofocals. That is, these are premium patients who ask for premium lenses. Of that, 40% of them opted for multifocals as compared to monofocals, which are imported. So that 60-40 ratio approximately indicates that there's a strong priority for me to choose in multifocal lenses as against the premium monofocal lenses. Monofocal also includes EDOF lenses, EDOF and monofocals, which are highly priced. When compared to that, 40 to 60 is that shows how much of bias I have for implanting multifocal lenses. And LRI, the main advantage of SICs is control of astigmatism. The LRI is only 2%. See, you know that there is a range of astigmatism that we need to cater. With that, can be catered with the SICs itself, modifying the wound. So LRI, that's necessary only in a very small percentage of our patients. Is that video visible?
Yes.
Fine. So I would like to show a video wherein the patient had an astigmatism. I had to choose a multifocal. Patient opted for a trifocal lens, and then I marked it. These markings are done using the various ways of marking the cornea. We use multiple markings, slit lamp markings, as well as vessel marking. This vessel can be identified on our optical biometer, and we mark it, and then we confirm the exact axis of placement by multiple methods, slit lamp as well as by the optical biometry. Then this is the technique that I would like to prefer. I start with a 2.8 millimeter keratome, 1 millimeter away from the limbus on the steep axis in this particular patient, which is horizontal placed. Inject a small amount of visco. It's not deepening the anterior chamber. Tunnel floor entry technique, which I often tell you, the entry is at the limbus, and I do a rhexis. The tunnel is not leaking, as you can see here. So the depth of the anterior chamber is maintained perfectly, and I can do a reasonably good rhexis. I'll go a little fast to save time. So that's pupil is dilated to about maybe 7 millimeters. And I've enlarged it to 5.12 millimeters, and I'm enlarging only the anterior aspect of the tunnel. This reduces the endothelial loss, as my observation is done in follow-up of these patients. So, the hydrodissection, rotate the nucleus, prolapse the nucleus into the anterior chamber, and extract it. under a continuous inflow of viscoelastic in front of the nucleus to separate it from the endothelium, as you can see there. A microvectis is a small vectis. This diameter is only 3 millimeter and about 8 millimeter long, and each heminucleus is aspirated. So what is happening is the technique involves least amount of capsular handling. There's nothing happening inside the capsular bag. The moment you've gone inside, you prolapse nucleus out of it. So capsular bag, even if there is a deficiency or even if there is a zonula weakness, it's not hampered. And the second is maximum endothelial protection because of continuous visco injection, as well as the phacoenergy itself can, though there are the modern techniques will minimize the loss of endothelial cells, the maximum endothelial protection happens in this particular patient. The only thing that is questionable in SICs is the amount of astigmatism you're going to produce. If you have a tight contour on the astigmatism by various techniques that are explained periodically, especially by Dr. Boramani, then it becomes pretty easy to control your astigmatism. So this particular technique will produce half diopter of SIA, which I take into calculations. The toric trifocal IOL, which I am aligning on the axis that's necessary. It's very important to remove the entire viscoelastic from the capsular bag. You have to wash it thoroughly, and entire viscoelastic from the anterior chamber is eliminated so that the lens does not rotate after that. You can see faint marks that are made on the cornea, and the alignment of the axis will be made in that meridian. So patients have been extremely happy. The two things that you'll have to titrate before you decide doing a surgery on SICs is amount of endothelial protection you're going to do, amount of SIA you're going to produce, and that is the axis, and I'm going to align it to that axis. And generally I ask the patients to lie down for about an hour's time so that it doesn't wobble during the post-operative movements. That's the end of surgery. So what I was trying to there's another case. Is that visible, Dr. Chitra?
Yes.
Fine.
Yeah, we do.
This is a case where there is a posterior capsular question mark subcapsular cataract, and we can still go ahead with the things that we generally don't do in a phacoemulsification. That is capsular separating hydrodissection and nuclear rotation are generally not performed. But in this technique of low fluidics, the pressure in the eye is very low. It's atmospheric or less than atmospheric, and fluidics is very, very gentle. And you can do a hydrodissection segmentally, as you can see here. You can see a central mass there. And when I do the hydrodissection, it's a capsular separating hydrodissection. You can see the mass getting separated from the posterior capsule. It's a segmental. I'm giving very tiny jets of the capsular separating. You can see the entire thing is separated now, as you can see there. And there is a bare posterior capsule. And now if I pressurize the anterior chamber, this bare posterior capsule can give way. So the low pressure technique is one which is very ideal. I am rotating the nucleus to separate all remnant of attachments, prolapsing it to the anterior chamber. And here is an advantage of a low pressure technique or a low flow technique, low fluidics technique over high fluidics technique, where you're not ballooning the posterior capsule backwards, putting it on tension. The other thing you can notice is the AC is absolutely shallow. It's shallow. There is a risk of endothelial damage, so I'm going very carefully with repeated injections of viscoelastic. There's no stretch on the posterior capsule. If you stretch the posterior capsule backwards, as it happens in a high pressure, high flow technique, and there is a possibility of tear. So I've done hundreds of these cases, and not even in one case I've torn the posterior capsule. So I'm very confident that I can give any kind of lens. So this patient has opted for a multifocal. You can see here, once you remove the posterior capsule, the pressure on the posterior capsule gets equalized, and the risk of posterior capsule dehiscence is minimal. So now I'm aspirating the cortex. The fluid that you need for the entire surgery is only about, on an average, about 30 milliliters of BSS. You don't need more fluid than that. The flow is very, very gentle, very smooth. And then you put a multifocal lens into the capsular bag. So multifocal lenses and toric lenses can be offered in SICs, provided you know how to control your astigmatism and you know how to protect the endothelial cell maximally. Otherwise, whatever technique that you use, ultimately you need to give a good emmetropia to the patient who is opting for a multifocal or a specialized lenses. I think because of short of time, I can end it here, Chitra.
Yeah, yeah, wonderful videos and wonderful explanation everywhere. Dr. Deepak,
Dr.
yes.
Dr. Ravindra, what you have said exactly, I want to say, we are presenting a paper recently, chronic IOL in SICs. Because
I just wanted to ask you this question only. Is there any special tip which you have to say when you are implanting a toric IOL in a SICs case?
Yeah, Dr. Chitra.
Yes.
There are two things important in toric IOL. Number one, when we take the IOL power, we take the site of the incision and the SIA. Everybody knows it. In SICs, when we are doing, everybody knows their astigmatism. I do incision at 6 millimeter incision at 90 degree, and I produce 1.25 millimeter astigmatism. Okay, so I know my SIA. So in toric IOL, what I am doing in SICs, we are keeping the site of incision 90 degree. We are keeping the incision size 5 millimeter. We know it will produce 0.75 or 1 millimeter astigmatism, diopter astigmatism. So we are keeping our SIA 1 diopter. In place of 0.25, normally we do in FECO. Site of incision 90 degree. And we have done more than 20 cases of toric IOL now in SICs with very good result, 6/6, 6/9 result. So you have to calculate SICs as per the astigmatism you are going to produce by the incision. At this site, you are going to give it.
Dr. Boraman, your thoughts?
Yeah, he's absolutely right. Surgeon should know what type of astigmatism is produced by your type of incisions. And if you are very confident about the surgically induced astigmatism, you can put it on the net on the various formulas, what the amount of surgically induced astigmatism, and you can put very well a toric IOL. But here I want to say that my use of toric IOLs is progressively reduced. I use toric IOLs for a very high astigmatism because most of the astigmatism, even up to 2.5 diopters, can be neutralized very well with your own incision. I got my own nomograms and they are working very well, at least in 90% of the cases. So the amount of toric IOL cases are very much reduced. And I also like.
Very good. I agree, sir, with you. But problem happens, sir, only when the incision site is not approachable. Then we have to put toric. Otherwise, you can control by SICs by incision all the toricity. This is the beauty of the SICs. This is beauty of the.
Is the steep axis is horizontal, then it is difficult to neutralize more than 1 or 1.5 diopters of astigmatism. Sometimes I used opposite CCI in such cases, SICs incision temporally and clear corneal incision nasally. That also works very well. And I am putting a lot of premium lenses like Dr. Ravindra. I am not into charity practice also. But if you are confident about your astigmatism, then you can put a lot of premium IOLs in SICs also. Even I hate calling it as a SIA because I call it always as a SCA. It is a surgically corrected astigmatism, not a surgically induced astigmatism. Because surgically induced is unwanted pregnancy, surgically corrected is a planned child. And here I want to make a comment, no financial interest, but now we have got beautiful progressive IOLs. These are the only IOLs of kind available in the world, which are varifocal IOLs. Varifocals are very well available in spectacles, but not in intraocular lenses. Now it is the innovation of Dr. Jagdeep Kakade and Dr. Ramesh Shah. They are Indian lenses, excellent lenses, because whatever bargaining you are done, like with all the multifocal IOLs are having multiple rings and their inbuilt problems like halos. The EDOF also is without ring, but in EDOF you have to do little compromise between the two eyes. One eye you have to adjust for distance and intermediate, second, intermediate, and near, because the range of focus is not full. But this progressive eye, the autofocus lens, is giving a full range of focus right from distance to near and without any rings. So there is no financial interest, but I think these are the excellent lenses and they are available in India. And I can call them as a super premium lens.
Dr. Kamaljit had a video to show on Argentinian flag sign in SICs. Does Dr. Kamaljit? I don't know what network.
Can I share my screen?
Yes, do share.
Am I visible?
Yes, yes.
Good. So this is about the SICs in a hypermature cataract. You can see that I have made the incision. I'll make it short because we are already past the time. So we stain the capsule, and here we start doing capsulorhexis. I do with forceps usually. Keep on injecting viscoelastic material. And while I'm trying to hold the capsule on this side, I'm trying to go, but it's extending a little bit, trying to prevent the extension to the posterior. And you can see there is a Argentinian flag sign. So here you can see this is a road that I've made. So what you can do is, for the young surgeons, you can give one nick here on one side and can simply make your round, not round, but half semilunar kind of rexes on that side. And on the other side also give a nick, small nick. And with the help of forceps, you can tear it off. So now you have a little bit safety, but only thing is that you should not use too much of viscoelastic material there. Otherwise the extension can further extend, and you make a larger incision and try to bring the nucleus in the anterior chamber. With little bit of maneuver, you will find that it will come out. Once it comes into the anterior chamber, whole of the nucleus should come in the anterior chamber. You can rotate it, bring it completely into the anterior chamber, and with the irrigating vectis technique, you can simply take it out easily. And then you can wash the cortical matter, and the aspiration is done. Once it is done, you inject the viscoelastic material. You have to see whether you have extended into the posterior capsule or not. If it is not, then you can implant the IOL easily. So this is what I wanted to show in a very, very short video that I wanted to share with you.
Wonderful video, and your network was very good. I think Allahabad networks become better after 8:30 in the evening.
Because it drinks one peg, so it becomes better.
Anyway, any other important question to be discussed before we conclude this very nice webinar? Any final message? SICs Jindabad, maybe.
Thank you so much, Dr. Chitra. You have arranged such a wonderful ARC symposium on SICs, which people don't like to arrange, but it's a wonderful surgery, and we have high volume centers here everywhere in India, and yes. SICs is coming handy.
Yes, yes, definitely. Yes, yes, very well said, very well said, and totally agree with you that every surgery well learned and well done has its own merits, and I think it has to be treasured, understood, and appreciated. I would like to conclude this wonderful webinar by thanking all my expert panel. In fact, even my speakers were truly giving expert opinion all through. It's just very unfortunate that we missed out on one or good speakers who would have added greater information of theirs too. And I suppose a weekday has its own challenges. And I would like to personally thank every expert panel and speaker who adorned this session. I would have to thank my co-moderator, Dr. Satyajit Sinha, who gives a lot of energy and through all these webinars. And yes, Anaga Harur, we can't ever miss the busy young lady who joins it, even if it's a very busy day towards the end and is with us. It's called giving a moral support to run a webinar very well. Thank you very much, ARC. And at this moment, I should thank Mr. Kripal and entire AIOS administration. We have to thank Sai and Manjula from Numerotech for all the mails which raid your inbox. I do hope nobody unsubscribes our ARC mails, but we are so passionate about this educative material we want to share and the kind of talent which is there in our country. We need to come back, do have to come back again and again. Very, very special thanks to Mr. Sunil, who needs to be given an ophthalmic degree for the amount of learning he has learned in all these webinars, which he very nicely conducts. And finally, most importantly, all of us in ARC owe our thanks to Entod for being our solid, strong sponsors through all our webinars over the last 2.5 years. Thank you very much to our delegates who watched these, attendees who watched these webinars, which has always been a great source of energy for us to keep coming back to you all. Thank you. Thank you very much.
Thank you, everyone.
Dr. Chitra,
Thank you,
before you conclude, on behalf of everybody who loves SICs and behalf of all the faculty here, I would like to thank you in specifically for so much of energy and enthusiasm your team has shown, which I've never seen before. You and Dr. Sinha and Dr. Anaga and the entire team deserves a great applause. Keep doing good work.
Thank you.
Ma'am, everybody should come to Chandigarh for the SICS conference.
Yeah, everyone should come.
Everybody. Yes, Dr. Boramani. Look, we are taking the charge of inviting everybody. You have to invite us.
Yeah.
Look forward to meeting all of you in person. Dr. Ravindra, are you coming too?
Yes, absolutely.
I need to be there.
Yes.